time. Good morning and welcome to the Dental Board of California quarterly meeting. Today is Thursday, August 23rd, and I want to ask all of us to please turn our cell phones to silent and make sure they're off the table so we can avoid feedback noise. If you notice the board members accessing their laptops during the meeting, they are using the laptops solely to access the board meeting materials that are in electronic format. This is an official business meeting of the Dental Board of California, and the board welcomes public comment on any item on the agenda. And it is the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand and you will be recognized. Depending on the number of people who would like to testify on a particular agenda item, a time limit may be imposed. We ask all speakers to please stay on topic, and if a time limit is determined to be necessary, keep your comments to within that time limit. I would like to call the meeting to order and ask the board secretary to please call the roll.
Yes, thank you. Burton?
Here.
Chan?
Here.
Chappelle Ingram here. Lai?
Here.
Larrin?
Here.
Lay?
Here.
Mackenzie?
Here.
Medina?
Here.
Morrow?
Here.
Alago? Pacheco? Stuart?
Here.
Witcher?
Here.
You?
Yes.
Mr. President, we do have a quorum.
Thank you. At this time, I'd like to just notice that I have appointed Dr. Bruce Witcher to chair the DAC meeting today until elections can be held at our next meeting. And at this point, I'm going to ask Karen to make an announcement regarding lunch.
Okay. Good morning, everybody. What you should have, board members should have before them a menu. And the restaurant isn't normally prepared to serve a lot of people at lunch. We've run into this before with other venues that have hosted our meetings. So Jerry will be passing around a sign-up sheet, essentially. We would like to put the orders in for board members by 10 o'clock so that when we break between 11:30 and 12:30, your lunches will be available. We're still anticipating taking an hour to an hour and a half lunch period to allow those that want to try to go out. But we have a very robust agenda this afternoon starting the Sunset Review Report. If we don't finish the Sunset Review Report, we carry it into tomorrow. So these are what the menus look like. Take a look, take a few minutes to look at it. And Jerry, you're going to be passing around something so that people can put the information down. I would recommend that you actually put it, pay for it by putting it to your room. If you're not comfortable with that, you can make that decision. But we want to try to make it speedy for you and so that you can get a lunch period. And if there's no other questions, thank you.
All right, thank you, Karen. Well, once again, good morning, board and honored guests. The dental board staff has been very busy and working hard since even before May to provide the Sunset Review background report, which is the main focus of this two-day meeting. This is certainly a rough draft, but we are looking for a good discussion in terms of what areas need clarification to better help our legislators understand how the board conducts its business. So, and staff will be providing updated statistics, and with our help, we'll continue to revise and refine the document. Another important focus of this meeting is SB 501. There has been recent major amendments relating to the board's recommendation related to pediatric anesthesia, and today we will have time to discuss this important bill. The Dental Assisting Council will be meeting today as well with the opportunity of orienting its new members. And I have appointed, as I just did, Dr. Bruce Witcher to chair that meeting, and I will respectfully ask all board members to remain in the room to listen to that important discussion today, if at all possible. Several weeks ago, the Department of Consumer Affairs called and led a DCA leadership teleconference call. And on that call, we discussed updates on the executive salary study, updates on legislation, updates on regulations, and updates on the budget pro rata. Specifically, we discussed the updates on the governor's budget and recent activities of the department's pro rata work group. Assistant Deputy Director Patrick Lay will be with us over the next 2 days, providing more information from the Department of Consumer Affairs. And finally, I've had discussions with Ms. Fisher regarding future participation in the AADB, the American Association of Dental Boards. We will look for ways to increase our participation to allow for California, specifically probably the presidents in ongoing years, to benefit from participating with that networking group. And with that, I think we can move on to item number 3, which is approval of the May 16-17, 2018 board minutes.
Mr. President,
Ms. Burton?
some corrections.
Yes, ma'am.
On the first page, under members present, Dr. Yu joined the meeting, but earlier votes indicated his absence. With other members, you've said what time they joined.
That's correct. We will look at the timestamp and insert that into the minutes.
Okay. On the second page, agenda item 3, line 2, it should be registered dental assistant instead of assisting.
Thank you. Any more corrections? Dr. Witcher?
Page 13,
Dr. Witcher, could you use your mic, please?
page 13, agenda item 9C, under public comment. This just needs to get looked at again. I think Dr. Rijardo's comments are accurate, but I believe Sarah Wallace responded to his comment regarding that the proposed language changes to minimal sedation would allow implementation at a reduced cost. And regarding the motion on the following page, I don't believe there was a motion to initiate rulemaking. I think the motion was to accept the report, just to approve the statutory language. And I went back and looked at the tape on the video, but you probably want to listen to the tape and see if that's worth changing.
So noted. Further corrections? Seeing none, are we ready to approve the minutes?
Move, Burton.
Is this a vote? Madam Secretary?
One moment, please. Motion to approve the minutes. Motion to approve the minutes. Burton? Yes. Chan?
Yes.
Chappelle? I was not here. Lai?
Yes.
Lay? Larrin?
Yes.
Mackenzie?
Yes.
Medina?
Yes.
Morrow?
Yes.
Alagi?
Yes.
Pacheco?
Yes.
Stuart?
Yes.
Witcher?
Yes.
You?
Yes.
Motion passes.
Thank you, Ben. All right, item number 4, we have Dr. Heidi Linser with us today, and she will give us a report on the DCA OPES regarding occupational analysis for dentists. Dr. Linser, welcome. Always a pleasure to have you here with us. We have to move.
Good morning, thank you. So I have passed out a handout to all the board members, and there's some additional handouts in the back of the room. So I thought I'd give you guys a picture today. I feel like I give you a lot of the same information over and over, so I gave you a little picture of our Office of Professional Examination, some of our staff members when we were having an open house. And so I hope that's a little more interesting. Let me go back, sorry. Let me go back a minute. Okay, so OPS, Office of Professional Examination Services, we provide professional consulting services in examination validation and development to DCA's boards, bureaus, and committees. And we've been doing a lot of work for your board. Very, very happy to do that. We're making great progress in all of your validation tasks that need to be done. So we make recommendations based on regulations, professional guidelines, and technical standards related to licensure examinations. So the regulation standards and guidelines that are informative for us are BMP Code 139, and that requires that boards conduct an occupational analysis for each examination every 5 to 7 years, and that's what we've been working on for all of your examinations. And boards also need to submit a report every year indicating the status of their occupational analyses and their examination development work. And we're just compiling that report right now. And it also required that OPS develop an examination validation policy for all of DCA licensing examination programs. And our principles and standards require that evidence of validity based on test content requires a thorough and explicit definition of the content domain of interest. In addition, a close link between test content and job content should be demonstrated. And so this is really the purpose. This is one of the main reasons why we need to do all these studies for you that you're paying for, is this occupational analysis work to thoroughly define the domain of interest that we're trying to test our applicants on. And most importantly, actively practicing licensees serving as subject matter experts participate in every step of the process. So, taking a look at the big picture, licensing examinations must provide a reliable method for identifying practitioners who are able to practice safely and competently. That's why we're here. And we also need to focus on entry-level tasks and knowledge important for public protection. So this is our cycle of examination development. We're always in the process of doing one of these steps. And today, of course, we're focusing on occupational analysis. So how do we determine what those tasks are that are important for entry level? Is we conduct the occupational analysis, and that defines practice in terms of the most important tasks that new licensees must be able to perform safely and competently at the time of licensure, and the essential knowledge that they need to know for safe and effective practice. And following the OA, we determine how to test the critical tasks and knowledge. We develop an examination outline depicting the weight assigned to each of the practice areas. Then we write test questions, we review test questions, we set the passing score for examinations, and then we start the process all over again. So, the occupational analysis of a regulated profession sorry, my slides are out of order, okay. So initiative, excuse me a minute, focuses, page. Okay, it provides a description of current practice, provides the basis for job-related fair and legally defensible examinations. It also gives qualitative and quantitative data to support the licensure of a profession. And it can help ensure that there are not artificial barriers to licensure. Once we know the details of the profession that we're trying to evaluate, we can make sure that our licensing requirements are consistent with those and we don't have artificial barriers. Provides the basis for legislation and policies as well. So as we said, it should focus on public protection, tasks that entry-level licensees must perform safely and competently, and tasks they should reflect situations commonly encountered by entry-level practitioners. So the occupational analysis process starts with telephone interviews and research. We have practitioner focus groups. They develop the preliminary tasks and knowledges. We actually draft the preliminary tasks and knowledges. In this case, for the dental occupational analysis, we were able to start with the last occupational analysis, which was done in 2005. We develop a survey instrument to send out to practitioners, asking them how important these tasks and knowledges are to their profession and how often they are performed. Then we analyze that data. And then we have an additional focus group review the data and make determinations about the final description of practice. So for this project, this was conducted by my staff member, Irene Wong-Chi. She's one of my senior testing consultants. And we started with a total population of the dental, of licensed dentists who had email addresses, and that was 14,277. And from that sample, we selected all dentists licensed 5 years or less, which was 2,866. As for us, the goal was to have 50% of entry-level licensees included in the sample. And then we, the remaining licensees from those who were licensed 6 years or more, those were stratified by county of practice and selected to total 5,823. So the goal is to oversample licensees 0 to 5 years, and that's to make sure we get that entry-level perspective. If we don't do that, we often get a lot more data from people who are licensed 20 years and greater. Even though that is wonderful because they're more interested in giving back. A lot of times they understand the purpose of these kinds of studies, but their perspective may not be the same as an entry-level perspective, so we want to make sure that we get that perspective. So the survey was sent to 5,823 licensees through email. The final sample size for data analysis was 1,046, which was a response rate of 18%. And that's a good response rate for these kind of surveys. We typically get between 10 and 20%. We actually got 36% response of people who actually accessed the survey and started completing it. However, many were not actively practicing, or they're not practicing in California. Some of them only completed a small percentage of the survey, so those people we had to eliminate. Practitioners also received 3 hours of continuing education credit for completing the entire questionnaire, and that does help with the response rate. And looking back, the last time we did your occupational analysis was in 2005, and we got a pretty similar, we got a 20% response rate, and that was, back then we were doing paper and pencil. So it's good that we're still able to get that good response rate. And because the survey was very long, it had 133 tasks and 338 knowledge statements, so that's a lot to ask a person to sit through. So let's talk about the results. First, we like to look at some of the demographics, specifically the ones that indicate that the respondent sample was representative of the profession in terms of experience, training, education, work setting, and geographic location. If we get too many responses from the same type of practitioner, then we might be concerned that we're not covering the breadth of the practice. So that's why we ask all these demographic questions. So with regard to education, 77% reported having a doctorate degree. I didn't make a slide about that because that was pretty expected. Also, the demographics help us interpret the data. So sometimes we might see something that we don't quite understand. We can go back at the demographics and look at how many people were in that practice setting to help us understand parts of the data. So this is years licensed as a dentist, and you can see that we have 58.5%. That big green blob there shows how many people were licensed 0 to 5 years. So we did get a really good response rate from those entry-level dentists. When you look at number of hours per week performing treatment on patients, you can see it's kind of the biggest areas are 30 to 39 and 40 or more hours. So we like to see that most of the people who responded to this survey were working almost full-time or full-time or more. Next slide shows number of patients treated per week. It shows a wide range in terms of the number of patients, so that should be representative of dentists who work different amounts of hours. Same with primary work setting. We see that it's spread across a variety of different work settings: sole practitioner, group practice, institution, dental corporation. This slide asks how tasks that the dentists are performing in their current practice. And this question asked, how often do you perform each of these tasks? I know it's really tiny up there. It's restorative was rated the most often, then prophylaxis, then fixed prosthetics, removable prosthetics, oral surgery, periodontics, endodontics, implant restoration, orthodontics, and implant placement. And again, we ask this question just so we get a feel for the respondents if they're practicing in these areas, because later when we're looking at the tasks and knowledge statements, if something is strange or we're saying, why is this not rated high, we can go back and say, oh, that's because very few people in this sample were doing that type of work. So this helps us explain the task and knowledge data that we're most interested in. So we also asked some additional questions about specialty areas, and those are in the report. And we asked some additional questions about the duties of the assistants in the office, because as we did a lot of work on your RDA program, this was of interest to the board. So we asked the top 3 duties performed by unlicensed dental assistants, and this was an open-ended question, so the respondents were asked to write in because we didn't want to put a long exhaustive list in there. So the respondents, the top 3 answers that we compiled the data, that we grouped it by similarity of what people said. So they said assist dentist or assist dentist chair side. They said prepare, set up and break down, clean room for patients, and they said disinfect and sterilize. So we also asked the top 3 duties performed by registered dental assistants. And this is the responses. The first one, again, was assist dentist chair side, coronal polish, prophylaxis, fabricate and place temporary restorations. Now, we had some feedback on this, the word, by the use of the term prophylaxis, but that's the term that the dentist used. But we believe that they were using that term to refer to the removal of excess cement. We understand they most likely were not referring to prophylaxis that's performed by dental hygienists. So for clarification, we have included this note that I have here in a revised version of the validation report, and that'll be available on the board's website, the revised report. But I wanted to wait till after this meeting to see if anything else needed to be revised. So this was a lesson to us to make sure when we're doing open-ended questions to review them and make sure that when we interpret them, we're interpreting them correctly. Next, we asked the top 3 duties performed by registered dental assistants in extended function. And the answers were take primary and final impressions, pack and place retraction cords, and assist dentist and dental assistant chairside. I do want to make a point about these answers to these professions is that there were in this sample, there were very few the respondents who were using the dental auxiliaries in their practice. And I don't know if that's a function of because there was a lot of entry-level people. So with regard to dental assistant in extended function, only 11% of respondents reported RDEFs in the office, 3% and 3% having one, 3% reported having two. So also with regard to the RDAs, 26% of respondents only had one RDA, 25% had two, 12% had three, and 22% have four or more. So it's a very tiny amount of the percentage of our respondents responded to these, had these auxiliaries in their office. Finally, we look at geographic region of where the respondents were practicing, and we like to see that we get some responses from all the different regions in California. So when we send out the survey questionnaire, we use a frequency scale. How often do you perform the task in your current practice? And how we also use an importance scale. How important is this task for effective performance in your current practice? For the knowledge, we use the same importance scale, just how important is this knowledge? So we develop a critical index for the value of each task and knowledge, and for the tasks, the mean frequency rating and the mean importance rating across respondents for each task was multiplied. And using this index, we reviewed the data from the task and knowledge, and we ensure that we ask our SMEs in the focus group to evaluate the task criticality in terms of both frequency and importance. So in other words, tasks that are very important but perform less frequently are get weight. Things such as report cases of abuse. That might not happen very often, but it's very, very important. And for knowledge, the critical index is simply the mean importance rating. So in the final practitioner focus group, the SMEs used the critical index values to determine if any tasks and knowledge they thought should be eliminated if it had a very low critical index. The SMEs determined in this case that all the task and knowledge statements are critical, and so no cutoff value was set. And even though the statements might not be performed often, the SMEs thought that all dentists must be able to perform all the tasks in the practice. So the dentist description of practice consists of 16 content areas, and part of the results of the OA are the specification of the weights for the various content specific sections of an examination. And so this we call an examination outline. If we were to do a dentist examination, this would be the content outline, the examination outline. For our purposes, we call it a description of practice because we're not at this point making a dentist examination of total practice. So these weights came directly from the survey data. We divide the sum of the task in criticality index for each content area by the overall sum for all the tasks in order to determine the percent weight. And then we ask the SMEs to look at that data and say, does this make sense? Now, in some cases, the SMEs look at it and say, no, this one looks a little low, or this one looks too high. And we have a discussion about adjusting the weights to make sure that they reflect what the SMEs believe is important. In this case, the SMEs believe that the weights were representative of practice, so they left the weights as indicated by the data. And here's a description of each of the areas, which you have in your handout there. So we have patient evaluation, endodontics, indirect restoration, direct restoration, preventative care, periodontics, fixed partial dentures, and removable partial dentures, complete dentures, implant restoration, oral surgery, teeth whitening, occlusal splint therapy, safety and sanitation, and ethics and law. And I want to make a note that content areas are somewhat arbitrary. There are many ways that a profession can be described or broken into categories, and we typically present as suggested content areas based on the previous occupational analysis, and then ask the SMEs to discuss them and come to consensus. And when we look at national examinations, we may see that they use different content areas, but still cover the same tasks and knowledges. So finally, we also looked at the law and ethics examination outline. So if you look, if we go back, we can see that ethics was determined to be 7% of the areas of the dentist description of practice. Law was determined to be 13% based on the frequency and important ratings. But we asked the SMEs to look at the law and ethics examination outline as a whole, and they determined that the breakdown should be 50% for ethics and 50% for law. They had the same amount, 7 tasks and 13 knowledge statements for each, but they believe that each should get equal weight on the examination. So next steps for your board. We are going to review, using the results of the occupational analysis, we're going to do a review of comparison study, I should say, to confirm the content areas covered by the American Board of Dental Examiners Adex examination. We're going to evaluate the breakdown of tasks and knowledges in your California-specific OA and compare that to the occupational analysis for the Adex exam. We're also going to review the Adex exam in terms of its exam development procedures, its occupational analysis, its test administration and security procedures to ensure that it complies with professional standards and guidelines. We're going to do the same thing for the REB. We've done the REB in the past, but now that we have an updated occupational analysis, we're going to compare and make sure that it's still consistent with what's measured on the REB exam, and also evaluate the procedures and exam administration and security for the REB exam again. And that's all I have. Is there any questions?
I have one, Heidi.
Okay.
Heidi, on page 8, under dentist description of practice, I understand, you know, those are the activities that were looked at. But when I see an area weight of patient evaluation at 13, then I look down at ethics and I see 7. I don't know how to put that in context. What does that actually, what am I to take away from that? As important as ethics is to a profession, it seems odd that it seems to be weighted less. Could you speak to that a little bit, help me understand what that means?
Okay, so the weights come from directly from the ratings of the tasks and knowledge statements. So when you have an occupational analysis like this, where there's so many content areas, there's only so much percentage to be distributed, for one thing. So the weights come from how important the respondents weighted the frequency and the importance of those tasks. And after all those were critical indices were calculated, then we looked at the description as a whole. And at that point, if the SMEs thought, well, really, you know, ethics should be given a higher weight, that was the discussion that they had to see if they believed that that should get higher weight than the data indicated. And in this case, they believed that those were representative. So it is from data and SME consensus that those weights are determined. However, your dentist law and ethics exam will have 25% law and 25% ethics, because we're not doing an overall examination of dental practice. We're only doing law and ethics because it's so important that 25% of that test will be law and 25% will be ethics. Does that help?
Dr. Witcher? Thank you, Heidi.
Yeah, just to follow up on that. I always am amazed when dentists can agree on anything clinical, or on much of anything, actually. But what's kind of telling here is if you look at the knowledge scale reliability on page 27, there's really good agreement among the subject matter experts on the various content areas. So, you know, there is some agreement apparently about how this is put together. I mean, I guess that would extend to the weighting as well.
And well, with so many areas, you can imagine, you know, the weight has to be distributed, and typically areas of actual patient contact are given more weight than law and ethics.
Mr. President?
I'm sorry, I don't know the order, so we'll start with
Dr. Linsker, this report trying to describe the universe of dentistry it's staggering. I do have a couple of questions on here, and start with maybe a little bit of a preamble. The license in California allows a broad range of tasks, and when we look at the entry level, which is this 4, is about the safety of performing those tasks. So another assumption is in the last census, the population of California was 39 million. 9 million is assigned as children. And yet when we look at, if you can look at table 17 on page 22, when you look at the majority of the tasks that are identified here and look at pediatric dentistry is more of an age description than it is a task description. And yet 61% is identified as those services performed in there. But performing those safely on a 1-year-old is different than a 2-year-old, different than a 5-year-old. The majority of the tasks that have been identified are done on adults, not in children, and not on very young children. So there's a gap in what I understand what we're looking at here.
And is pediatric dentistry a specialty area that someone at entry level would be practicing?
The license allows that to happen, yes.
Well,
The purpose of asking this question is that there appears to be a gap. The entry level allows you to do that.
understood.
And yet, and it looks like it's being performed, and yet performing it safely on a 1-year-old or 2-year-old is not the same thing. The tasks that have been described or asked of the sampling pool is all, majority of it, as I see it on page 22 on the table 17, are all adult tasks. They're not done on kids.
Understood.
Yeah.
And on the national exams, I mean, when we look at the national exam, that's something we could look at to see if pediatric dentistry is pulled out as, if there are tasks and knowledge specific to pediatric dentistry. So that's, because your assessment of your dentists and their practice, their abilities and their task and knowledge related to practice is going to be on your national examination. So when we do the evaluation of the national, we can look to see if pediatric dentistry is given additional weight. Because this is a description of practice remember this, we are not testing based on this examination plan. You're testing based on your national exam. So we can look at that and make sure that pediatric dentistry is represented. And we will definitely take that into consideration.
Thank you.
Yeah, so I understand the importance, obviously, of getting a higher response from the 0 to 5. And so I think you said anyone in 0 to 5, you sent them the survey, and then it was a smaller percentage for people practicing beyond that?
It was 50-50.
Oh, okay. So why wouldn't you just send it to everybody, anyone you had email? Because you could always slice the data with the 0 to 5 versus the higher, the additional number of years.
Well, when we send it to everybody, we often get a skewed response of more responses. And then we would have more responses from people licensed 20 years and greater.
Right,
So
but you can filter for that.
Right, but we like to keep the data from everyone, so we decide to do the sampling up front to make sure we sample, so then we can keep all the data that we receive instead of filtering the data.
Okay, but then you're also speculating, like when you talk about the RDA and the RDAEF, you're speculating that the reason the numbers are low is because there's a higher percentage, so then you still have to make assumptions then
Yes.
on the other side, right?
Yes.
Rather than have the information and, pull it out and look at exactly what you want to look at.
Yes, but those questions were adjunct questions that we asked. Those weren't the focus of the study.
Thank you. Thank you, Heidi, very much for your work. It's an exhaustive and a thorough report. Being in dental education, my primary source of knowledge about examinations having to do with the practice of dentistry are entry-level students. If you look at California with our 6 dental schools, we have in the neighborhood of 600 to 700 students that graduate on an annual basis and are taking some type of a licensing examination in order to obtain a license. So I think the occupational analysis, for the purpose of looking at and assessing the Adex exam and the REB exam, again, primarily needs to realize that we're looking at entry-level knowledge, skills, and values. And this report, to me, was very enlightening from a standpoint of education, because I'm looking at 600 plus students that are graduating from California dental schools, and how does their education fit in with these knowledge bases, skills, and values that we're saying that dentists in the state are experiencing and employing. So it's a valuable tool for education to look at. Also looking at it from a standpoint of Commission on Dental Accreditation and the standards. Basically, the definition of graduating a dental school that's approved by Quota is that the graduates possess the knowledge, skills, and values to enter the unsupervised practice of general dentistry. So unsupervised entry-level examination. And I know we have people here that are from Adex, I know, and my assumption is that their examination is geared towards that entry-level knowledge, skills, and values, rather than 5, 10, 20 years of practice. So it has a depth of knowledge and information here that can not only be used by us as licensing agencies, but also by the educators in the state to evaluate the quality of our education based on what is being done out in the practice field at the same time.
Thank you, Dr. Morrow. I'm glad that it has other uses. We know that it can help provide transparency to candidates of what knowledge and skills they need to know.
Dr. Lyncher, I see restorative at the top of the list in terms of tasks performed.
Mhm.
And then I look on page 22 and I see amalgam restoration. And I'm but I don't see composite. Was it broken down in terms of why is amalgam, what does it mean when with amalgam giving a number of 487? Help me understand that.
Let me look at that. So, table 17, we asked all the respondents, are you, let's see, are you performing any of these services? And so 46% or 487 respondents said they were performing them. Now, this table is just for the board to get and for you to get an understanding of all these different specialty areas of what of people are practicing. This wasn't we didn't necessarily cover all this in the occupational analysis because a lot of these are specialty areas that weren't determined to be entry level. But it was just for the board's information to see what people are doing in their specialty practices. So that was 487 people said they were doing amalgam restoration. And your question was?
Yeah, I guess I was
don't know.
asking why we were talking about amalgams,
Amalgam
but
and
not
not composite.
understanding what the trend is with amalgam versus composite. Which
And
is-
this, again, in the workshop, we would ask SMEs what services are of interest, what do you want to ask? And that apparently didn't come up, was not listed as one of the ones that they were interested in finding out. And they may have tried to, whittle it down so it wasn't so long.
So a takeaway is that amalgam restorations is still a big part of the practice of dentistry in 2018, is that?
Well, of this sample, now again, it has to be qualified by the sample. 50% were practicing 5 years and less. And so that's what the data show from this sample.
Thank you, Dr. Linser. Abigail?
Yeah, my question is on regards, and I agree with Meredith, on regards the how it was tested and how it's disseminated. When you look at page 4 for the first slide, and you look at the geographic and region, and then when you look at the booklet that you sent on page, I just passed it. But anyways, regarding the locations, I see that there's a high concentration in Los Angeles, San Francisco, and even San Diego. How are locations, how are they picked, or how are they passed out with regarding different locations that they're?
So for this sample, for people who are licensed 5 years and less, we did not look at their region. We took all of them because we wanted to make sure they were included in the sample. For the people who were licensed 6 years and greater, we selected them by county to make sure to try to get all the different counties in California. But in every survey that we do, we always get more data back from Los Angeles, San Francisco area because there's more people. So we always
But then
get
regards,
more.
like for instance, Riverside as an example and vicinity, you mean the surrounding locations? Would you have, like for instance, San Bernardino County as well? I'm just looking at the areas where,
At the end of the report, it's broken down in more detail.
okay.
And these were collapsed categories. So at the end of the report, it's actually by county.
Yeah, I was trying to look for that, okay. Okay, thank you.
Dr. Witcher?
On the scan of the, let's see, it's like page 32 all the way through 66. It describes some of the tasks and some of the questions on these tasks. And realize the preamble of this is to look at entry level and to perform the function safely. And there seems to be only one question that talked about proper referral to a specialist, and it was very specific to ortho but not the other specialties like pediatrics or surgery. And the object of the question, I would hope, is when you're way over your head, when do you need to refer? And yet it was only directed at ortho. So I don't know if that's a question or statement. Sorry.
And which page is that one specifically on?
Page 32, right at the bottom. It's task 11.
That's the one.
And again, it's the preamble of health
Okay,
and
so
safety.
the K30 would say that require referral to a specialist, so that would be to any other specialist. So the task says refer patients to specialists when dental treatment needs exceed practitioner abilities. So that would refer to all types of specialists, the way the task is written.
I need to digest that a little bit. Yeah.
And you have to understand, as you were saying, the scope of what dentists do is extremely broad. There's a lot of tasks and a lot of knowledge, and to try to collapse it into a readable form that isn't, in the old days, we used to do these and they would be 300 task statements. And it's not workable as a description, it's not workable to collect the data. So over time, we have refined the way we write the task statements, and sometimes they're more general, and we try to capture more things in every task and knowledge. It's not going to be a perfect capture of everything you do. So it's meant to be, an overview of what you do, knowing that at the time when people use this, and same for your national, when people use this to write test questions, they have a huge breadth and depth of knowledge. So this would be a jumping off point for someone to write a test question and make sure that they cover everything. So it may not be as specific or as detailed as it could be, but it's to represent that area of knowledge. And so for your educators and for your people who are using it to write test questions, it's meant to be a placeholder for knowledge on that area, and then they would write test questions more specifically or develop educational tools based on that concept.
So I'm kind of still wrapping my head around that, where in experience, it's within the first 5 to 10 years that you're, as a practitioner, you're exploring your boundaries, you're exploring your frontiers also. And yet, where does the licensure exam capture when do you know where your borders are and not transgress that? And I'm not sure how to ask that question in terms of the initial licensure.
I think, so if we were writing an exam on this area, that's why it's really important that subject matter experts such as yourself, except that you're on the board, so you wouldn't be able to come, but subject matter experts such as yourself would come and write a test question and say, this is really important, and especially in this, if I saw this in a patient, it's really critical that this patient be referred. So that's why when you get to the level of writing a test question, you can get to a more detailed point of those critical areas. So this is meant to trigger you to think of, oh, I know a really important scenario that needs to be asked.
I just want to give a quick input for page 22. As a dentist for so many years, right now I basically only do 1 or 2 amalgams per year. 1 or 2, that's it. The rest are all composite. Thank you.
Yeah, I think the idea was to see how many people are still doing amalgam, and they knew that everyone did composite, so that was why it wasn't included.
Dr. Morrow.
I think it's also important for us to remember that this occupational analysis was done for a number of different reasons, but one of which was to look at the content of the Adex exam. Licensing examinations are not limited to clinical, but they are also written. Our license in California requires passing of appropriate written examinations as well as a clinical examination. We're looking at a clinical examination specifically as far as the Adex exam is concerned. And a lot of the competency, assessment of competency, is not on a direct clinical basis, but on a written basis and on a case scenario basis, where you have a case that's presented to the candidate, a description, some radiographs, some photographs, medical history, list of medications taken, and then questions are asked regarding that scenario, which is also testing competency, but not on a patient, not a clinical test, but a written test. So licensing is not just the clinical exam, based on the clinical examination. It is based on multiple factors, multiple types of assessments, not just patient-based.
Maybe one more question, Dr. Insert. In terms of process, I'm looking at the dates on your cover sheet, and it looks like it took about 6 months. Is that an accurate in terms of the process from start to finish? Is that
Usually takes about 9 months.
about
Usually-
9 months?
Not 9. Irene is very quick in this. We actually got really good participation on this project, so we did it a little quicker. But usually takes 9 months, because there's that time where the survey is out, and that's a couple months there.
Dr. Witcher?
What's the next step with this? I don't see that there, it doesn't seem to be an action item.
In terms of we were just presenting the report because the board needs to know how we do these things. So there's no action on the report. And then Heidi, Dr. Linser had indicated what the next steps would be since this has been completed in her presentation. She said then we start with actually looking at the outside exams. And so there's nothing that needs to be done with this to accept the report. It's just here so that the dental board members are aware of what's done and what our process. I would also add that for the new members to understand, and for our seasoned members to understand too, while Heidi's talking about an occupational analysis that we do in order to do our exam review, you can also take this information that you've learned now, and as you're looking over your discipline, see, is there a correlation between the things that she's outlined here in terms of where their training was, how long they've been in practice, and to see whether there are any trends that you can identify in the discipline that comes forward. Particularly your comment about, has pediatric dentistry really not been fully looked at? Yet does our discipline that we're dealing with that comes before the board, is pediatric dentistry impacted? And I would say the answer is no, fortunately. So we can have some understanding, or the board should have some comfort in knowing that even though certain aspects may not have been covered in this, that for the most part, everybody has a pretty safe record out there. But so just take this idea of understanding the occupational analysis. We need to get back on board and have this done on a regular basis, and so that we have current information to be able to affect all the decisions that the board makes. I think that if you see some of the tests that are there, you can see that we've had a rise in implants and restoration of implants. Also in the pie chart that she gave in the PowerPoint, look at how sole proprietorships have gone down and corporations and group practices have gone up. That, I think, will have a direct effect on where the board will be focusing in the future.
I guess just one additional comment. Dr. Morrow was talking about this is going to be beneficial for the dental teachers and the educators. And when I see so many of our our cases that come before us do have an ethical component. And oftentimes we're asking people to go back and get a little bit more education in that area. Do these numbers reflect that maybe we need to do a better job within the school setting to elevate the ethics training, or is that a takeaway or not?
That wasn't really one of the questions that we were asking, and as far as this study was done, but I think it's across all boards now, boards and bureaus and licensing entities, that ethics are extremely important, and that's why most boards have a separate California-specific exam to make sure that law and ethics are assessed when they didn't used to have that, so.
Thank you, Heidi. Any further questions?
Just one question.
Yes,
Yeah,
Dr.
okay. Well, thank you, Dr. Licensure, for the report. I know your next step will be to review the Adex exam and also the rep exam, and how you, like, so that they will, whether or not they match, what your findings, indicate. So can you give us like a timeline of how long the reviews will take and when a recommendation will come to the board?
We're waiting for Adex to finish their occupational analysis. I'm not sure when that's going to be done, but when it's done, then we have contracts to start as soon as it's done, and it takes about 6 months to do the review and analysis, assuming we get all the data that we need in a timely manner. So it takes about 6 months. I don't know when our contract's supposed to start, but.
So the Sarah Wallace, Assistant Executive Officer, the review of the Adex examination, the contract has begun, although we are waiting on the final results of the Adex OA, and so that will push back that timeline. So we originally believed it was going to be completed in early 2019, so I would say probably early to mid 2019 at this point. We can expect to bring back a report to the board and then discuss that at that time. And then we're right now reviewing contracts to review the REB, the portfolio, and the law and ethics examinations over the next 2 years.
And we try to time our reviews so that of course, our OA is done now, but that the exams that we're reviewing, their most recent OA is also done so that we can coincide with the same practice time that we're assessing.
Dr. Tom?
Sir. Dr.
Just, I have received a number of inquiries recently regarding the availability of licensure in California through the Adex exam for the graduates from dental schools in California in 2019. So what I'm hearing from you is that probably unlikely that there will be approval of the Adex exam for that graduating class.
I'd like to respond to that. It's going to be a longer process, and if you'll recall, the board had discussed accepting Adex, but in a certain format, which was a portfolio type of format. So once the Adex evaluation has been completed and Dr. Licensure says they're good to go, then I would anticipate the board needs to develop regulatory language to essentially say the Adex exam is accepted in California, but in the portfolio, in the delivery by a portfolio method, which we'll still have to talk about. So because the Adex passes the requirements of BMP Section 139, there are more steps that need to be done. And since we have new board members here, we'll have to sort of start from the beginning and give a historical background of the discussions that have taken place to this point and see how the board wishes to move forward, whether there's still a consensus of wanting to establish a certain type of delivery of the exam, or whether they just want to accept the traditional delivery of the exam.
Dr. Chan.
Point of information for maybe our staff. How many licenses, dental licenses, are issued per year?
On average, we issue approximately 1,000 new dental licenses annually.
And then just so that we can put this out, then taking the California dental law.
Now, that's from all pathways.
Right. The dental law and ethics, is that a separate section in all the different pathways? And then that's the calibration, right, for the ethical part of it and the law part of it.
The only pathway that does not require the law and ethics is the licensure by credential pathway.
Okay, thank you.
And if the board feels that that needs to be changed, now would probably be the time to bring that up. We'll have to determine whether that needs a statutory change and/or a regulatory change. So if you feel that law and ethics would be required for licensure by credential and for the benefit of the new members, that means people who've been licensed outside of the state for 5 years have the ability to come in without taking an examination. So if the board believes that law and ethics should across the board be given to everybody, now would be the opportunity to bring that up, and we can perhaps stick that in our sunset review report. Dr. Witcher has a-
Dr. Witcher.
Just to address that, there is a requirement for California law and infection control that has to be taken for renewal of the license. So they at least get that. In other words, if they're issued a California license, then they have to meet the requirements for renewal, which includes a required course in California law that it has a little bit of ethics content. That's not the focus.
Yes, that's correct, and they also have to complete the mandatory continuing education courses, which include the 2-hour Dental Practice Act and the 2-hour mandatory infection control course upon initial application.
Would the board entertain the thought of a subcommittee being appointed to look into this and see if it needs licensure by credential needs another look in terms of the ethical component?
Yeah, I would encourage us to consider the addition of the law and ethics exam for licensure by credential as a requirement for that license portal.
Ms. Burton?
If that's a motion, I would second that. I don't think we need to study it before, unless I'm missing something.
Yeah, that's a motion. That was an
Okay.
informal motion.
Okay, well then I would second that.
Okay.
State that motion once more.
We consider addition of the law and ethics examination as a requirement for licensure by credential.
Can I offer a little bit of guidance here? This isn't agendized.
Not right.
So, Michael, is it okay to be discussing this when we're talking about our new items for consideration in sunset review?
Yes, the discussion kind of tangentially relates to the report, so that's fine, but we should put that on the future agenda items.
All right. Thank you, Michael, for that. Dr. Morrow will bring that up in a little bit.
Guy Champagne, Adex. Just to update the board, the occupational analysis for dentistry and dental hygiene is completed. Actually, we received the report 2 weeks ago, similar to what you just received. It might be of interest to the board to know that this is my third occupational analysis process, and with everyone we get these questions that the board has posed. Because now ours is more maybe narrowly focused because it's for exam development only, but one of the answers to the questions is entry-level dentists don't do pediatric dentistry at that level. So we ask those questions. In our survey, we say, do you perform? Do you delegate and supervise, or do you refer? So we follow what entry-level dentists do. And for exam development and protection of the public, we have to test what they do, not what we want them to do, not what they could do under the license, which of course is going to change over time. For example, we even in our survey have cosmetic procedures. We thought that would make the cut score this year. It does not. So Botox injection, things like that, entry-level dentists aren't doing, even though they could do it under their license. But Dr. Morrow brings up an excellent point. If you look at our crosswalk and our blueprint, literally 60% of the items tested is tested in our computerized OSCE. You cannot do a performance exam on surgical complications, pharmacology, medical evaluation of the patient, diagnosis and treatment planning. These are all case-based things where the candidate has to ask for the records, ask for the radiographs, ask for the medical history. And so if you look at the crosswalk, literally 60% of what we test is tested in our computerized OSCE. The performance component are the non-delegable skills that a dentist has to do and does do in entry-level practice. So we did ask, we found, but between composite and amalgam, and you are accurate, when our cut score is applied, amalgam does not make the cut this year. So nationally, composites have, as the impression is taken over in restorative dentistry. However, amalgams are still done. So for our exam, that's one of the reasons we have 2 restorative procedures. You have to do a composite because that makes the cut score across the board. But because people do amalgams, it's an option on the second restoration to do an amalgam if that's the material you're going to use. So there may be a dentist, and there are some dental schools that teach amalgam as a primary restoration. They're few in number, but we have to be able to include that in the exam. So we see these same questions, but for exam purposes, when we develop an exam, we have to test what they are actually doing, and that's going to change through their career. We thought placement of implants might have made it this year. It doesn't. Our data looks just like your data. It really, I mean, you could have mirrored the two, and we're happy to provide that to you, both the occupational analysis and the blueprint of the exam, which would make the crosswalk easier.
Dr. Stuart? Yeah. So Dr. Champagne, I have a question for you. So does your OA include both formats of your exam, the curriculum integrated format and also the traditional?
Okay, well, yeah, all of our exams now are curriculum integrated format. So the only exam we give that is not a curriculum integrated format is dentists who are in practice moving someplace else to going to a state. So in every dental school we go to, it is a curriculum integrated format. And so every school that we go to, the faculty can approve the treatment plan, approve the sequencing, when it's done, what the appropriate follow-up care is, if that's follow-up care, what lesions are treated, what lesions should not be treated. That is throughout our entire exam system. So that is now just an integral component of the exam, as well as giving it multiple times through the school, because if the school wants to set it up that way, we go to schools where the patients don't know it's an exam because that's the treatment they're getting that day in the clinic. We check it and then the faculty check it. So that option, it's an institutional prerogative. So some institutions say this is what we want to do in our dental school and they ought to have that prerogative. But that's throughout it. But the occupational analysis itself doesn't influence the format. It influences and dictates what we have to test and what we can't require too. It's the other side of the coin too. It also defines, we don't want an unreasonable barrier to entering the practice of dentistry, knowing that a practitioner 10 years down the line is different than somebody 2 years into practice. So we can't include procedures that are so complex we would eliminate people from entering dentistry.
Thank you, very helpful. I see another hand in the audience. Dr. Linser, thank you so much for being with us, and thank you for that report. All
Thank
that hard
you.
work. Thank you. Please, come up.
I'm Dr. Richard Sobel, and I'm representing the California Society of Pediatric Dentistry. And I know you've already heard from Dr. Chan related to pediatrics to some degree, but we would like to put some statements in. In the review of the content, especially the content of the occupational analysis of the profession, not as was just discussed, the occupational analysis of the examinations, we noted deficiencies related to care of children and their oral health needs. Interestingly, 61% of the respondents said that they perform pediatric dentistry, which was a fairly large number, and especially since 50% of the people were new practitioners, I assumed somewhere in that same range, new practitioners also perform some pediatric dentistry, not the super specialized portions. However, knowing that data, there is no mention of knowledge or tasks, certainly knowledge for sure, and or tasks to be demonstrated for children. This includes areas of growth and development, restorative care for children, surgical treatment in very young children and also those in the mixed dentition, and occlusal and space management. Also, very importantly, there is no best practices in behavior guidance for children, young children versus school-age children versus what an adult would need for behavior guidance. Hopefully an adult would not need behavior guidance, but this is especially critical in our profession. However, having said all of that, most importantly, the safety and the care of children needs to be included, and that is not mentioned at all. And finally, the statement that Dr. Chan just pointed out, that there probably ought to be some increased emphasis on the referral or the need for referrals when it's appropriate for care of children, but that applies to every other specialty as well. Thank you very much, and if there's any questions, I'll answer them.
Points taken. I see another hand. Please come to the.
Morning, Mr. President, board members. I'm Anthony Lum from the Dental Hygiene Committee, Executive Officer. And I just wanted to point out one clarifying area in your report pertaining to the RDAs and their top 3 duties that are performed on page 21 of the report. I appreciate that there's been a revision and a note added into this area. However, even the notation that was added really can cause some confusion as far as who can do a prophy. And since RDAs are technically not allowed to do prophies, and by definition it should be done by a dentist or a dental hygienist, I would request that that term be removed, if at all possible. Thank you.
Thank you, Dr. Thank you, Tony.
Thank you. Good morning. I'm Maureen Titus from the Center from CDHA, California Dental Hygienists Association. We've already heard some discussion about that, and that's particularly what I was going to be bringing up, and I like how Dr. Morrow made a comment about some education. Some of our concerns over this regarding this occupational analysis seems to be there's a lack of understanding on the scope of practice for dental assistants and RDAs and RDA-EFs. On table 15, top 3 duties for RDAs, number 2 duty was listed as chronopolish and prophylaxis. There definitely is a legal difference between these 2 duties, and an RDA cannot legally perform a prophylaxis on a patient. On the questionnaire on 17, if the dentist were the ones who put those in there, that is definitely a concern, because if they are coming up with that, they're not familiar with the legally allowed duties by auxiliaries. And if a dentist is allowing this to happen and they're billing insurance, that could be considered fraud. So it was interesting that the dentists were asked if they employed hygienists or RDHAPs. However, they weren't asked if they understood that scope of practice. They were also asked again about the familiar scopes of practice of the different auxiliaries. And on table 12, page 19, it says 92.5%, or 968 dentists out of 1,046, stated yes, they were familiar with the current scopes of practice. But based on that, I'm not sure that they do. So maybe that needs to be a different education also. Also, I was a little concerned when it talked about the occupational analysis of dentist, and they were also including auxiliaries in this, so I didn't quite understand that. I thought it was a little bit confusing that it was asking more than just the practice of dentistry by dentists. So, thank you.
Dr. Witcher?
Yeah, is Dr. Linzer here? Oh, I think you actually, you and I had a sidebar, and I think you have a response, maybe?
In regards to what?
Term prophy,
Yes.
and I believe that term was used in lieu of removal of excess cement with hand instruments, the removal of excess cement with ultrasonic scaler from supergingival surfaces of teeth undergoing orthodontic treatment, and the polishing of surfaces of teeth.
Yeah, well, remember, this was an open-ended question, so the dentist, this was their response, and we believe that dentists meant prophylaxis in terms of what RDAs can do.
Again, that's not the legal definition of prophylaxis. So I think we need to be, if you're going to do a study like this and spend all this money, we need to be extremely accurate in our definition of what a prophylaxis is, what a corona polish is. So that's my concern, that perhaps the dentists that you surveyed don't truly understand the scope of practice, don't understand the definition. And as Dr. Morrow said, maybe that comes in with some more education.
Thank you. Okay, I see another person coming to the mic. Please.
Is it on or do I have to hold it? We good to go? Hi, Claudia Pohl, CDAA. We would concur with the previous comments regarding the verbiage of prophylaxis and understanding of scope of practice. I will not reiterate that. I do have a question regarding the examination outline, and I don't know if this is for Dr. Linzer, but as per the content area description, the law is to assess the candidate's ability to comply with legal obligations, but the knowledge statement, which is K323, states that it's the knowledge of laws and regulations that define the dentist's scope of practice. So I'm not sure why, but it appears to me that it should also have a knowledge statement that there is knowledge of laws and regulations that define auxiliary scope of practice, and that would underscore what we've just had, because dentists also need to be knowledgeable about the scope of practice of all auxiliaries, not just their own scope of practice. So I don't know if that was an omission or if that's something that should be considered to be included and how that gets done.
There's another statement about supervising.
But that
auxiliaries.
statement, if you
Yeah.
read that statement, it doesn't, it addresses how they supervise. It does not address supervision as it relates to the delegable duties. And there's a distinction there. So that's in T132 as opposed to T123, and I think there's a distinction.
So I just want to make this point I made earlier, is that these tasks and knowledges are meant to give an overview of the description of practice. When we actually write the test questions, we have subject matter experts come in, dentists, who will write the questions and cover the scope, and it will cover the scope of what dental assistants and dental hygienists can do.
Okay, because that knowledge statement doesn't reflect that here, so.
But I believe it's part of supervising.
But the statement in supervising doesn't reflect, I don't have it in front of me, but it doesn't state, it just talks about how to supervise assistants, and that's very different than, are you understanding the legal obligations of the people that you supervise? Very different knowledge statement.
And I'm trusting that Heidi will take that information back.
Yes.
Thank you. We're going to entertain one more thought from the audience, and then we're gonna just for everybody's comfort, we're gonna take a 15-minute break.
Lisa Okamoto, CDHA. Dr. Stuart reminded me that there have been some comments about amalgam restorations. I read recently that because of an international agreement, amalgams will be phased out, including in the US by 2020. Given that it is optional to use a non-amalgam restoration in the rep exams and Adex, I'm assuming, is there any consideration given to making a non-amalgam restoration a requirement?
Does staff have any knowledge of that recommendation, phasing out amalgams by 2020?
I'm sorry, Dr. Stewart, I read this recently, and I tried to quickly go through my files, but I couldn't find it yet. I will try to look for it tonight and give that information to staff.
And I would say we don't have a comment at this point. This is the first time we've heard of it, and the board has not had it come before them.
All right, thank you. All right.
I just have a comment to that. So amalgam now, there's new amalgam without mercury. So I don't know if that's true. I guess the poisonous component is mercury, and the new amalgam does not have mercury. So I don't know if that's true or not.
I think it's time for a short break. Let's take 15 minutes, then reconvene. Michael made me do it. All right, thank you. We are on agenda item 5. Discussion and possible action regarding renewal of board's approval of the University of De La Salle Bahia School of Dentistry. Dr. Morrow, I believe, is taking this.
Thank you, Dr. Stewart. Just as a little bit of history and reminder, in February of 2018, the Dental Board received the University de La Salle Bahia School of Dentistry's application for renewal of board approval of their dental education program. Following review by the subcommittee that was appointed, consisting of Dr. Hong Lei and myself, the application and the supporting documentation, the subcommittee requested additional supporting documentation related to educational standards identified in California Code of Regulations, Section 1024.1 C6, C8, and C9. On April 25 of 2018, Karen Fisher, Executive Officer of the Board, submitted a letter to Dr. Jorge Triana Estrada, the Dean of the School of Dentistry at De La Salle, requesting the subcommittee's additional supporting documentation. That supporting documentation was received by the subcommittee on June 29 of 2018. Following review of the requested additional supporting documentation, the subcommittee has determined that, in their opinion, the University de La Salle Bahia School of Dentistry is in compliance with the institutional standards as identified in California Code of Regulations, Section 1024.1 A through L. Therefore, the subcommittee recommends the Dental Board of California grant renewal of approval of the University de La Salle Bahia's School of Dentistry program.
Okay, so,
Dr. Lei.
okay. Thank you, Dr. Morrow, for that report. So at this point in time, it is the opinion of the subcommittee, Dr. Morrow and myself. We feel that the school has met the requirements for reapproval. The school has demonstrated that they have worked very hard to maintain and also improve the quality of education provided to their students. The documents that we received have demonstrated that. So what I would like to do is I would like to make a motion to the board to accept our report and also to reapprove the Dental School of De La Salle
Thank you, Dr. Lay. We have a motion. Do we have a second? Dr. Chan. Any discussion? Dr. Chan.
So just point of information, the approval is for how many years?
The approval is for 7 years. I guess I do have one question now that I made the motion. The school actually submitted their reapproval a year early, which is unusual, and I have to applaud, the efforts, in doing that. So if we do approve the school today, how does that work?
Well, I read your mind.
Okay.
I had 2 weeks ago, and Michael and I had this discussion. So yes, it's wonderful that the application materials were very clear and thorough. This was a huge change from the last renewal period where a site visit was conducted. It was determined that they had no physical changes or no changes to their physical facilities, so another site visit would not be necessary. Michael, you can weigh in on this. They're in the process of finishing up their Quota approval. So should they get their Quota approval, they will no longer have to come back to the board for approval. But it's a 7-year renewal, and Michael, we talked about whether the 7 years essentially would start from today, or technically they don't expire until May of 19. So if you'd like to weigh in on what you think.
There's nothing in the Business and Professions Code that specifically says when the renewal will be effective. So we can go off of the expiration date, even though they submitted it early. So the motion would be to grant the renewal for additional 7 years, starting from the date of expiration of the last time it was 2019. Yeah.
Question? In the event in 7 years, they do not pass Quota, can they come back to California and ask for an approval?
Yes, they're required to, if they don't pass Quota, they're required to continue to renew with the board every 7 years.
All right, any further questions before we take a vote? Dr. Chan?
This may not be germane to the motion, but the question is, does the statute identify Quota for U.S. schools, or does it have to have a modifier for international schools? I mean, I don't know what the statute says for approval. Quota is Quota is Quota, but does it say for U.S. schools or Canadian schools or international schools?
Now, are you asking the question based on what the dental
Yes.
board accepts?
Yes,
Okay.
yes.
Well, that's also a very timely question that I think we're going to be discussing during Sunset Review, because we've heard, Sarah and I, as long as we've been with the board, which is about 10 years, have heard how the board accepts Quota. Well, we have determined that statutorily, Quota is only mentioned in very narrow areas of the Dental Practice Act. So if your intention is to accept Quota, whether it's international, whether it's national, whatever, we probably need to clarify that moving into Sunset Review. I'd ask you to think about that, because do you want to just accept Quota across the board for whatever they do, or do you still want to maintain discretion on how to use that? So that's a separate issue. Foreign dental schools go through an international review by Quota. So I would anticipate that they're still using the same criteria that they'd use for national schools to evaluate the equivalency of foreign schools. So for the board's purposes, if you're Quota approved, you're Quota approved. Does that answer your question?
Could I, just for a little bit of clarification, Business and Professions Code 1634.1 having to do with requirements for licensure. So the approval of foreign dental schools has nothing to do except for licensure, okay, in California. So requirement for licensure, 1634.1. Completed application form, which is obvious. Satisfactory evidence of having graduated from a dental school approved by the board or by the Commission on Dental Accreditation of the American Dental Association. So at this point in time, foreign dental schools go through the approval process so that they can meet, their graduates can meet that licensure requirement that says they had to have graduated from a dental school that was approved by the board. If we struck by the board and simply said by the Commission on Dental Accreditation, now that the Commission on Dental Accreditation has an international process for approving foreign dental schools, which was not in existence when this code was originally written.
And thank you for your comment. That comment actually should be repeated when we go into our sunset review issue on approving foreign dental schools. It was completely
Was
appropriate.
informational at
Yes.
this point
Yep,
as
yep,
well, so.
Yep.
Yeah, and I think, you know, earlier when you mentioned that if the LaSalle does pass the quota, then they don't have to come back to the board for approval. It sounds to me like it's, if a school is quota approved, that it would be approved by the Dental Board of California then?
And
Would
this
that be
is,
the
this
right
is a
interpretation?
discussion, this is a discussion we need to have, because in the history, in the brief history that we have, we're assuming that our California schools, because they're quota approved, that everything is fine. Though this board in the most recent past has only approved Western. So I don't know that there are dental records going back, that all the other 5 dental schools actually sought approval from the board. I don't know, it's an interesting thing, you know, we'll get it figured out. It sort of opens this Pandora's box that I was waiting for this afternoon to open, but you guys wanted to open your present early, so I'll just give you something to think about when you're eating lunch, but yeah. So, yeah, it's a little bit of a tangled web that we'll see if we can sort out.
If I could, just a little quick clarification of that. I'm sorry.
And with Western, if I recall, we sent a couple of people there, but it was an easy process. It was not this process that we go through, that we've been through with the foreign schools that we have approved.
That, I agree with you, Fran. That visit to Western followed Western's quota approval, okay? And if you look at the California Code of Regulations, section 1024A, it says a new school for the study of dentistry in California shall apply for provisional approval in its first academic year. Western University was the only new school in California after that regulation was enforced. That's why we visited Western to approve them, because that regulation says that a new school, if another new school happens in California, we'll do the same thing. But it wasn't in existence when UCLA, USC, so forth were in existence. So.
Yeah. Dr.
Lay.
Yeah, I just want to make a quick comment, and Van is correct. I think the site visit at Western, which is it was almost like a courtesy site visit. It was me, and did you come or was it Dr.? Okay, so anyway, so it was more like a courtesy site visit because they had already got approved by Quota. So anyway, we didn't really review the curriculum or do a lot of those things that we had to do with the LaSalle, or other dental schools. So.
Thank you, Dr. Lay. How about public comment? I think we have a motion and a second. I think we're ready to record the vote.
Yeah, let me repeat the motion. So the motion and the second are to accept the subcommittee's report and to approve the Universidad de La Salle's application for renewal effective May 2019.
Okay. Burton? Chan? Lai? Lay? Larrin? Mackenzie? Medina? Morrow? Alagi? Pacheco? Stuart?
Yes.
Witcher? You? Motion passes.
Thank you.
Congratulations to the representatives from De La Salle are here. Congratulations. We'll be sending a letter to the dean acknowledging the board's decision.
Thank you. All right, I think we're moving on to item number 6, and we have, I'm going to ask our 2 new members for the Dental Assisting Council to please come to the table, and Cindy Friel-Ovard and Pamela Peacock will give us a little bit of a personal history and just whatever they want to say. This is 2 minutes fine-free, so take your time and welcome.
Good morning. Thank you. A little bit about me is I was born and raised and still reside in the Bay Area. I started my career as a registered dental assistant 35 years ago, graduating from Contra Costa Community College. When I wrote that, I realized, wow, I have really been in the field 35 years. After graduating, I worked as a DAU RDA in the Pediatric Clinic at UOP, the School of Dentistry in San Francisco. For the past 21 years, I have worked for Contra Costa Health Services, and for the past 8 years as lead RDA at Contra Costa County. I manage 5 ambulatory clinics and 2 jail clinics, and I'm also the care coordinator for specialty care, cancer patients, oral surgery, and the OR cases. In addition to my duties as lead RDA, I represent the dental department on several committees: the Infection Control Committee, Contra Costa Oral Health Steering Committee, Dental Imaging Expansion Project, Detention Health Safety Committee, and Detention Specialty Care Improvement Committee. In 2009, I obtained certification as a certified sterile processing and distribution technician. In addition to my duties, I felt this was an asset to the department to keep sterilization to what it should be in today's world. Currently, I'm a member of the Golden West Central Services Healthcare chapters. I'm a patient advocate and enjoy helping those patients that are less fortunate in the community and very passionate in providing quality care for all of our patients. In my free time, I enjoy spending time with my husband, 5 children, our son-in-law, grandson, doing outdoor activities such as boating, fishing, camping, and I'm an avid gardener. And one of my passions in life is I've accomplished several, and I continue to do so, half marathons. I walk them for the Leukemia Lymphoma Society. So.
That's quite a resume, and did I miss your name?
Oh, I'm sorry, I'm Pamela Peacock.
I missed it, so thank you, Pamela. Welcome.
Thank you. Thank you for the opportunity.
Wonderful.
I'm Cindy Ovard, and that's quite the resume. It makes me think I didn't write anything down, just free for all. I have been in dentistry and dental assisting for pretty close to the same time Pam has. I started out of state, and I moved to California in 1989. Did not realize that I had to become an RDA, so I was working, and the doctor asked me to show proof, and I couldn't. So he said, oh, you need to go get your RDA license. So I did, and in 92, I became an RDA for California, and it was great. I worked ortho, I worked general, I worked a bunch of different offices, but I got into teaching in about 2003, and I still worked offices part-time while I taught part-time. But about 6 years ago, I went teaching full-time, and I'm with San Joaquin Valley College, Temecula. So I'm in the Temecula, Southern California region. And I think my favorite class to teach is radiology. I love radiology, so. What else about me? I am the program director for San Joaquin, and I love teaching students. I love teaching a new career for people coming in, and dentistry, I have a passion for dentistry. I love dentistry. I love the teeth, I love the mouth, I love oral health, and I look forward to serving on the Dental Assisting Council.
Thank you, and how's your gardening?
My gardening? No, I don't garden. I don't cook.
All right, we have one gardener on the group. You know, I just want to say that the Dental Assisting Council is an extremely important part of this body, and we really appreciate your willingness to come and share your time and your resources and your knowledge with us, and we look forward to just a great participation with the Dental Board. So thank you so much, both of you. We're going to bring the DAC group up now to take their places at the table, and we will give them some room so we can go out. And if at all possible, please stay with this meeting. And I'm going to ask Dr. Bruce Witcher to chair the meeting. So, Bruce.
Okay, if we could have all the DAC members come up to the dais, please.
Yeah, and if board members can just maybe close up your binder and make space for the DAC members to find a space to sit up here. Now, board members have to go into the audience, and as Dr. Stuart said in his opening remarks, he would hope that you would stay and listen to the discussion today so that you're aware of it.
Good morning. Welcome to the Dental Assisting Council. Today is August 23rd, 2018. I'm Dr. Bruce Witcher, member of the council and the board. And as Dr. Stuart mentioned, he asked me to chair this meeting until elections can be held for a chair and vice chair, possibly at the next meeting. The council welcomes public comment on any item on the agenda, and is the council's intent to ask for public comment prior to the council taking any action on any item. If for some reason I forget to ask for public comment, and if you wish to speak, please raise your hand and you will be recognized. Depending on the number of people who would like to testify on a particular agenda item, a 2-minute time limit will be imposed. We ask all speakers to please stay on topic and only bring new relevant information that has not been previously addressed before the council. If you would like to go on record in support or opposition of a certain item, please identify yourself, the organization you are representing, followed by support or oppose position. With that, I would like to call the meeting to order and ask Jerry if she would please call the roll.
Contreras. Here. Davis Washington. Here. Olagi. Here. Ovard.
Here.
Peacock. Here. Rodriguez. Not here. And Witcher.
Here.
We have a quorum.
Okay, and there's item 2 here, which is introduction of new members. We've heard from Pam Peacock and Cindy Ovard. Thank you for that. That was nice. Maybe the other members could maybe just go around and reintroduce yourselves. And I know we know Rosa here a little bit, but maybe say a few words about yourself too. So Pam, do you want to start off? Turn on your mic, please.
Sorry. Pam Davis Washington. I'm the clinical member of the that committee, and I work in Long Beach at a Children's Dental Hospital next to Memorial Hospital. And I work on kids from the ages of 0 to 20 months, 21 years old actually, and mostly medically compromised kids. That's all.
Good afternoon, everyone. My name is Ann Contreras, and I serve as the faculty member here at DAC, and I currently work at Pasadena City College and Cerritos College. During the summer, I still work chairside, and I've been in dentistry for about 23 years, and dentistry is my passion as well, and I've been serving on the council since the beginning, and I love every moment of it, and welcome to the new members.
Yeah, we have to acknowledge that both Pam Davis and Ann have been members since the council was formed, so they've really hung in there over the long haul and had some turnover, but they've been the constants. And Pam, I think you're occupying the RDA clinical position, and Cindy, you're RDA educator position, and Jennifer Rodriguez is our RDA EF member, and unfortunately she couldn't be here today, and would that will affect some of our discussion, I think, because we need an EF, to help us with one of the agenda items. And I'm Bruce Witcher. I'm the board member liaison to the council, and just interface between the organizations. And I'd like to see this be the council's meeting, and then of course our RDA member, my wing person, from the board for doing this.
Good morning, I'm Rosalinda Olagi. I've been with Pacific Dental Services for 10 years now. My undergrad is in psychology from the University of La Sierra, and I'm currently pursuing my master's in business from the University of Redlands. I'm really excited to be part of the DAC, and my goal is to really elevate the profession as a whole for dental assistants, and I'm excited to be part of this committee.
Okay, thank you. Moving along to item number 3, we need to accept the May 2015 meeting minutes. Now, some have asked, why are the meeting minutes that old? That was the last separate meeting of the council. Since that time, the council has been meeting as part of the board, so the minutes of that meeting are in the board minutes. But when the council meets separately, it will need its own minutes, so those will need to be approved. Now, some of you were not there at the time. I think only 3 of us were that are present, so we will have to approve the meeting minutes, and you should abstain since you weren't there. And I believe with 3 we'll be okay to approve them.
I'm sorry, Michael, I thought that we had the option of just accepting the meeting
okay.
minutes?
Yeah, let's do
rather
that
than having to approve? And
Okay.
therefore, everybody could accept?
Okay, thank you for that, because I think we are kind of shy of a quorum, so, for this, only because, it was the people who were there at the time. So with that, I'll go ahead and move acceptance of the minutes, and if we have agreement on that.
I'll second it and
Okay. Very good. Okay, thank you. Moving on to the next agenda item, we have a presentation by our dental assisting manager. I'm sorry? Oh, I think, do we need to move it, or? It was just by
No,
unanimous consent?
By
Yeah.
unanimous consent, we can do that way.
Yeah.
There's no
okay.
need for a motion.
Thank you.
And just one quick mention on acceptance of the minutes. Technically, there's no requirement that you be present at that meeting to accept the minutes, so long as you read it and you believe that it is a fair and accurate representation, then that's fine. You can still actually vote. So normally people do abstain if they weren't present, but again, there's no prohibition that you can't vote on it.
Thank you for that. Okay, with that clarification, we'll move ahead to our presentation on overview of the Dental Assisting Council.
Sorry, just broke the microphone. Good morning. My name is Sarah Wallace. I'm the Assistant Executive Officer of the board. And I wanted to introduce with me today Ms. Tina Valerie. She is the new Dental Assisting Program Manager. She took over the management of the program in June, and she's had a very busy 2 months. Tina has had extensive experience with the dental assisting program. She actually came over initially when the program came over when COMDA was abolished, and we inherited the dental assisting program. Since that time, she's worked in various capacities at the board, including in enforcement, in dental licensing, and in dental assisting. And so she's a subject matter expert in various areas of the board and a jack of all trades and my right hand. So I'm very pleased that we were able to hire Tina. At this point, I'm actually going to give the presentation. We thought it would be helpful with the newest members coming on today to have a brief overview of the Dental Assisting Council. We provided this brief training back in 2012, I think Pam and Ann, and I think Cindy, you may have been there as an educator as well. So we just wanted to give an abbreviated version of that training today to give a little bit more background on the creation of the council and what the responsibilities of the council are and how they will work with the board. So we've already made introductions. So welcome. You've already met Karen Fisher, our executive officer. I'm Sarah Wallace, the assistant executive officer. Michael Santiago is our legal counsel for the board, and then we've already been introduced to the dental assisting council members. Give you a brief overview of the board and the dental assisting council. So the board is responsible for the licensure and regulation of dentists, registered dental assistants and extended functions, and various permit holders. They serve the purposes of their licensing and regulatory functions by reviewing applications for licensure and permit, issuing licenses to qualified candidates, assuring initial and continued competence. We receive complaints from consumers, and we investigate those complaints and take disciplinary action against those licenses. We are also responsible for managing a diversion program. The board's mission is to protect and promote the health and safety of consumers in the state of California. We accomplish that mission by ensuring that we're issuing licenses to competent applicants who possess the necessary educational requirements and have met all of the licensure and examination requirements to be able to have a license in California. We enforce the continuing education requirements and ensure that consumers are informed of their rights in relation to verifying dental licenses and enforcing their complaints. As it relates to the consumer complaint process, we open up complaints and we'll promptly and thoroughly investigate those complaints. If there is a warranted violation of the Dental Practice Act, that will be followed through to disciplinary action with the AG's office. The board itself meets at least 4 times per year, usually in San Francisco area, Los Angeles area, San Diego, and Sacramento. We have several standing committees of the board for examination, enforcement, licensing, legislation and regulation, and the Dental Assisting Council. We also have other standing committees as needed. The council itself was established by Senate Bill 540 in 2011, and the initial council appointments were made in 2012. The establishment of the council is contained in Business and Professions Code Section 1742 in your Dental Practice Acts, and that code section outlines what the responsibilities of the council are, what the composition and the requirements of membership are, etc. As Dr. Witcher pointed out, the composition includes 5 RDA members, one of which has to be an RDA-EF, the RDA member of the board, and another member of the board. The appointments to the council are made by the dental board. We accept applications from qualified candidates. Typically, a board subcommittee reviews those applications and makes recommendations to the board for appointment. As established in statute, the Dental Assisting Council is responsible to meet in conjunction with other board committees. Typically, this has only happened at the quarterly board meetings. In the recent past, we've been holding joint meetings with the full board and the Dental Assisting Council. It's dependent upon what issues come forth. And the council meeting agenda items are established through the approval through the board president and executive officer. Should any council member or stakeholder wish to request the establishment of an agenda item for a future board meeting, the request should be sent to the board president and the executive officer to be placed on the agenda. Quick overview of the dental assisting program within the board. Tina Valerie is the licensing manager of the unit. This program is responsible for the licensure and examination of all of the RDAs, RDA-EFs, and then we also have the orthodontic assistant permit and the dental sedation assistant permit. So Tina manages the examination processes for all of those licensure categories, the licensure application processes for all of those categories, as well as the renewal and the continuing education requirements. And we've included a little breakdown of what our current stats are for active license and permit holders. So just a little bit more of an overview, the functions of the program. We have several staff that will review the applications. They travel to the examinations to administer the RDA-EF. We have several renewals that we're processing. We take in all of the fingerprint results that are required as a result of initial licensure and renewal. And we are a unique program where we are reviewing and approving the program and course applications for dental assisting educational. So how did the dental assisting program come to be part of the board? Initially, the dental assisting program was part of the Committee on Dental Auxiliaries. There was a bill in 2008 that essentially abolished the Committee on Dental Auxiliaries and created the Dental Hygiene Committee of California, which moved the dental assisting program under the board as of 2009. So since 2009, we have made several changes, significant changes in the scope of practice and the requirements for licensure as a result of AB 2637, which became effective in 2010. And we've been revising the dental assisting educational program and course regulations that have been effective since November of 2011. So you'll hear us talk a lot about AB 2637 and the development of our regulations and the impact that it's had on the development of our licensees and the new requirements. So functions of the Dental Assisting Council. As established in statute, the Dental Assisting Council is responsible for considering all matters relating to dental assisting in California. And then the statute goes on to list all of the applicable areas. We consult with the Dental Assisting Council on these various areas. The council has been an integral part in the development of the comprehensive rulemaking package as well that cover all of these requirements. And of course, the issues we've been dealing with the practical exam for the RDA leading up to this point. Once the council reviews issues, they have the responsibility of making recommendations to the board, and then the board can make a policy decision based on the council's recommendation and pursue legislation or regulation or process changes. The board and the council's priority is the protection of the public. We do this in exercising all of our licensing, regulatory, and disciplinary functions. And it's important to note that whenever the protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. And we exercise this mission in everything that we do with the dental board. So one of the biggest questions that comes up is what's the difference between a statute and a regulation? And you'll hear us talk about statutes and regulations a lot, especially with dental assisting. And so pretty much all you need to know is that a legislation or a statute is a piece of law that's established via the legislative process and has been signed by the governor. From the statutes, we have the Rulemaking Authority, and a rulemaking is also considered a regulation to implement, make specific the statutory requirements and outline them in a more strategic way to implement how we're going to make that statute applicable. So the regulatory process is done in-house. We have legislative and regulatory analysts that work on the development of regulatory proposals, and we go through that approval process, and the board itself has the rulemaking authority. We have to file it with the Office of Administrative Law, and we're going to go into that in a minute. Just to back up a little bit to the legislative process, that involves the Senate, the Assembly, stakeholders, the development of language within that process. There are 2-year legislative sessions. Next session is not 2013, 2014. We are actually in the second year of a 2-year session. Next session will be 1920. During the board meetings, we will review tentative legislative calendars and review the life cycle of a bill. The process includes drafting an idea, creating language. It needs to go through various committees, which we track as part of our legislative program with the board, and we report back to the board regarding the actions that the committee have taken and the action that the governor has taken. Once the governor takes action, then it'll become law. How can the Dental Assisting Council be involved with the legislative process? A lot of the issues that the Dental Assisting Council discuss, whether it's issues that come up that are staff generated or issues that are generated by the council or even that of stakeholders, may need to require statutory implementation before the board can make it effective. And so the council can be involved in that process by developing the idea and the rationale behind why it's needed and present those ideas to the board to potentially pursue legislative change. So the regulatory process can be lengthy and arduous. Essentially, there's 6 standards that we have to meet in order to justify the need for a regulation. All of our regulations live within the California Code of Regulations, Title 16, and we have a rulemaking authority in statute and Business and Professions Code, Section 1614. This goes into the regulatory process, which is quite lengthy. Essentially, what you need to know is that it's it's an open process where stakeholders are encouraged to participate. It's transparent in that we accept comments in relation to the proposed text. The board has to consider comments that we receive and respond in an open forum to those comments. And everything is contained in the rulemaking package to justify the need for the changes, and then goes through an extensive review process with the Department of Consumer Affairs, our agency, Department of Finance, and then finally the Office of Administrative Law that ensures that we've met all of the necessary requirements to make this an effective law. So these are the various steps that we have to go through. Rulemakings can take 18 to 24 months. So how can the Dental Assisting Council be involved with the regulatory process? Well, the Dental Assisting Council is very involved right now. Actually, we're working on a comprehensive rulemaking package. Initially, there was a rulemaking that went into effect in 2011. It covered some of the areas of educational programs and courses, but we really need to update the whole package in terms of applications, examinations, then the program and course requirements. And so the Dental Assisting Council over the past 2 years, as well as several stakeholders, have been working in stakeholder meetings to develop proposed regulatory language. Our final stakeholder meeting was held earlier this year, and we are in the process, staff is in the process of putting together that final draft language to present back to the council, hopefully within the next 6 months or so. And then that was just a very brief overview of what the council does. I wanted to just provide a little bit more information, but we'd be happy to answer any questions that you might have as well. And always feel free to reach out to either Karen or myself or Tina if you have any questions relating to the process or need additional guidance.
Thank you. I know we have some handouts on the legislative and regulatory process. I mean, they're on the web and they're not too hard to find, but I think those are very helpful for people who haven't seen that before, who haven't dealt with it too much.
We can email those copies out.
Yeah, those are good. Okay. Well, if there's no questions, we'll move on to the next agenda item. Item 5, update on RDA program reevaluations and dental assisting program and course applications. And I think, Tina, you're going to take this one?
I am. So the board has 2 analysts that review and process all program and course applications and program reevaluations. This memo provides an overview of the reevaluations that are currently underway, as well as the program and course applications and the status of each application. Page 2 is an overview of the current programs that have been notified that we are reevaluating their program. These programs have been sent applications and been requested to submit their curriculum along with the completed application for our review. As of August 1st, 2018, we have sent out 30 reevaluation notices. Of those 30, 4 programs have notified the board of their closure. 1 program we have not received a response from. 10 programs have requested extensions, and 15 have sent in their curriculum for review. Of those 15 programs that have submitted curriculum, 1 program has been approved, 6 are under review by staff and subject matter experts, and 8 are currently deficient and are being notified and working on those deficiencies. Page 3 begins the overview of the programs and course applications. Table 1 shows that we have received 40 applications to date and provides a breakdown of each application received in 2018. Table 2 shows that we have conducted 9 site visits this year. Table 3 is an overview of each application status. And Table 4 shows the total number of approved programs and courses. And if anyone has any questions or comments.
I just wanted to share a little bit more background with the new members in terms of the reason we're doing these reevaluations. As a result, let me initiate this with, we currently do not have any backlogs in the initial application of programs and courses. 4 years ago, we had backlogs, and we've had adequate staffing and SME resources, and we've recruited additional subject matter experts to be able to handle the workload associated with the initial reviews and approvals. As part of our current regulations, we also have the authority to conduct reevaluations of programs every 7 years. Unfortunately, leading up to this point, we haven't been able to maintain compliance with that due to limited resources. We're finally now at the point where we have the staff, we have the resources, and we have the time to be able to initiate these. Additionally, as part of the suspension of the practical examination, the board and the council had really emphasized the need to get into the programs and conduct the reevaluations to ensure that they were maintaining compliance with our requirements and that they were teaching to the standards that the board had as requirements, and that was being translated into the written examination so that you could see the correlation. And so as such, we had developed a plan to do the reevaluation. Essentially right now, the reevaluation appears as we're requesting these programs to essentially reapply. They're applying on the same application that a new program would apply on, ensuring that they're providing all of their curriculum requirements. We're asking for the same information. A site visit may or may not be warranted. It's dependent upon what the findings of that requirement are. So this isn't a new process. We have the authority to initiate the reevaluation of any program at any given time if it's deemed warranted, but we also have the authority to do it every 7 years. So this is our opportunity to get back on track and make sure that we're in compliance with our regulations.
I have a question. The the 4 programs that closed, were they closing anyway, or did they close because we were asking for information?
It's my understanding they were already closed.
I also have another question regarding the 4 schools that closed down. Since you guys are doing a study for 50 schools, if those schools are already closed, are you counting that as one of the 50, or are you going to replace it with 4 other schools separately so that you'll have a data of 50 total schools?
I'm not sure where the 50 came from. So we're reviewing all of the existing programs, and we're doing that in increments of 5 letters per month. So maybe that's how we're getting the 50. So increments of 5 schools per month are receiving letters. No, we're not replacing. If we receive notification from a school that they've closed, we're not sending it out to an additional school. It's based on the 5 that we have on the list.
Okay, so basically it's going to be pretty much all the schools that are licensed as a provider.
Yes.
As an RDA.
As an RDA program.
Perfect. Okay, thank you.
Another question. It states that they have to return everything within 6 weeks. If they don't return it within 6 weeks, what happens?
We've had several programs request extensions, and so we're working with them on that. Other than that, I mean, it's a case-by-case basis, so at this point, we're willing to work with the program to make sure that they have the adequate time to put that together.
Question. So schools that were recently approved within the last, say, 3 or 4 years, will you review those also, or wait for 7 years, or wait for that 7-year time frame?
We should be waiting for the 7-year time frame. We're talking about schools that have been approved for 20-plus years and haven't had any reevaluation. So,
how do you choose which ones? It's just random, 5 every week or every month?
It's somewhat random. What we've tried to do is prioritize which programs probably need to have the review happen first. That was based on the results that we've compiled from the written examination. So those schools that are showing a higher failure rate are obviously our priority, and we're going to reach out to them first and review those curriculums first.
I think another criteria was the time since initial approval, because I know there's one school that was in the top 10% of test scores, yet still is being audited. And I think it was because their application was so long ago that there was a need to determine currency. And Rosa, I think you had a question?
Yeah, so the 8 schools that are deficient right now, is there trends in those deficiencies, or what are we seeing as commonalities with those 8 schools?
I actually don't have the details of their deficiencies at this point, but just in conversation with the staff, it's just certain pieces of the curriculum that aren't included. It might be for the Pit and Fisher or the Corona Polish. I think it's misunderstandings in what we're looking for.
Okay, if there's no other questions, this isn't oh, I'm sorry, Ann, go ahead.
Sorry, one more quick question. Are you guys going to also review standalone courses down the line?
Possibly, yes. Ideally, yes, that would be the ideal situation. But right now, we have upwards of 100 RDA programs that we need to get through first, and then we'll do the courses eventually. I'm hoping, though, that with the regulations, that's probably going to clarify a lot of the issues, and we'll get certifications of compliance with the updated regs at that time.
Perfect. Thanks.
Just to comment, from what I understand, the reapplication, it's like 3 binders, and the amount of staff work involved in going through it is pretty significant. So I'm glad you're up for it.
It is, and I wanted to make a comment. I've heard from a couple of stakeholders that there's a lot of confusion at the programs as to what's required for the reevaluation process, and that there's programs that are in anticipation of getting their reevaluation letter. We're working on an email newsletter to be able to send out on a monthly basis to the dental assisting program directors and the course directors. But just to clarify, it's not a new process. It's the same process that you went through with your initial application. And if you have any questions, or if you are contacted by anybody that receives questions, feel free to send them my way. And Tina and I are more than willing to field those questions and make sure that the educators have the most accurate information.
Even though this isn't an action item, I'd like to ask if there's any public comment. Okay, seeing none. Moving along, update on dental assisting licensing statistics, or examination statistics, I'm sorry, number 6.
Currently, the board offers 4 written examinations: the newly launched RDA Combined General Written and Law and Ethics exam, the RDA EF written examination, the Orthodontic Assistant Permit written exam, and the Dental Sedation Assistant Permit written exam. This memo provides an overview of the candidates that have been tested over the last 12 months and the passing and failing scores for each exam. The tables also break down each examination by first-time and repeat candidates and their passing and failing scores. The board also offers the RDA EF clinical and practical examinations, which have been offered in February and May of this year, and a breakdown has been provided for this examination as well. We have also provided numerous pages of statistics for each program approved by the board and what each of their passing scores are. And if anybody has any questions, I'd be happy to answer them. I apologize. And we have these statistics posted on our website through July of 2018 as well.
Question, I noticed that the statistics here are combined, north and south. Are we going to see them combined from this point forward?
Which one are you referring to specifically?
On the first page, before, I know in the past you guys have had statistics north versus south.
So that, I
I
think-
didn't know if you guys were gonna keep it this way from this point
I
forward.
think what you're referring to is for the RDA practical examination.
Yes.
They're either north or south within a specified month. For the
Right,
RDA EF exam, it's one exam per month, so there isn't a location. But we can add whether or not it's north or south based on the month.
Okay, perfect, thank you.
I think that comes up because there was a north-south disparity on the practical.
On the RDA.
Yeah, right.
Right.
Okay, any other questions on exam statistics? It's good we have the combined exam out there and up and running. That was something we needed to do. Okay, next item, update on dental assisting licensing. Oh, I'm sorry.
No, I
Yeah.
just, I couldn't get my,
Cindy,
I
yeah.
couldn't push the button fast enough. When the results are given to the students, the candidate who takes the exam, it just shows a passing. Do they ever know what their percentage was? I've had comment on wanting to know the
We're
percentage.
gonna get that to that in the update on the combined exam.
Oh, okay.
Yes.
Okay.
Okay, update on licensing statistics.
The board currently licenses in the dental assisting unit RDAs, RDA EFs, OAs, and DSAs. This memo provides an overview of the number of licenses that are current and active, current and inactive, and delinquent. This item also provides a breakdown of licensees per county and the ratio of RDAs to DDSs licensed within those counties. Beginning on page 4, there are tables indicating the number of applications received by the board in 2018, as well as those that have been approved, that have been approved, licenses that have been issued, and applications that have been canceled, withdrawn, and denied. And if anyone has any questions about those.
I guess, sorry.
Go ahead.
I guess my question would be more, I see the stats for that, but when the exam is given or completed and they leave the table and they go out to the front and they get a passing paper that says they passed, will there ever be a percentage of what they might have missed or what categories? Because the exam is in units. It's on, patient care, and then the next part is infection control. Will they ever get any statistics on what part, if they did not pass, what they maybe need to study and focus on more?
So Tina and I attended a meeting in April with dental assisting educators where we were getting feedback. I think it was dependent upon which PSI, and PSI is the testing vendor that we
Right.
utilize for the internet-based testing. It depended upon which testing location candidates were going to at PSI and what PSI was generating as far as their failure scores and which components they were failing on. And so looking into that more, and with the launch of the combined exam, we've put in the request to PSI to make sure that if a candidate fails the examination, that their printout is printing out what they need to focus on next and which components they've
So
failed on.
what category they might have,
Yes.
percentage-wise, what
Yes.
they
So
failed.
that should be
Okay.
happening now.
For every PSI.
For every PSI
Okay.
location. If you become aware, and again, to the dental assisting educators, if you become aware of one of your students who've taken the exam and they failed and they didn't get that printout, if you could please let us know to make sure that we're in contact with that individual location. But that was our direction given to PSI, that they needed to convey that.
I do have one question. On the dental assisting application, on the statistics, is it, and for the RDA, EF, and all the rest of them, is that the initial application, or is that for ones that have not passed the first time around and reapplied?
So these statistics would be based on new applications.
Okay, thank you.
Okay, seeing no further questions. Moving along to number 8, regarding combined RDA ethics exam. I anticipated that, thanks.
At the meeting in May, the May board meeting, we reported that we were in the implementation phase of the combined general written and law and ethics examination. From May 15th through May 23rd, candidates were not able to schedule the RDA written exams while PSI or testing vendor prepared for the conversion to the singular examination. The combined exam was launched on May 24th, 2018, and candidates were able to begin scheduling their exam. From May 24th through July 8th, candidates were issued a participation letter that explained that their examination results would be held while a quality assessment was performed, and that they would receive the results by mail in 4 to 6 weeks. Results began being mailed out to those candidates and issued on site on July 9th. And the board did experience a slight delay in receiving the results from PSI due to a Breeze interface issue. This was resolved rather quickly though, and once we began receiving those results, licenses were able to begin being issued. As of June 30th, we have tested 299 applicants. 8 were in May and 291 were in June. As of July 24th, we have issued 241 licenses to applicants that have passed the combined exam and completed all other licensing requirements. The pass rate for this examination is currently at 54%, which seems to remain consistent with the 2 previous examinations. And if anyone has any questions, I'd be happy to answer them.
Just to clarify for the new members, the combined examination wasn't the development of a new examination. It was the combining of 2 existing examinations to reduce potential barriers to licensure and alleviate some of the financial hardship that a candidate may have to have in applying for the 2 separate examinations.
Who combined? Who took that task of combining?
The Office of Professional Examination Services.
Okay.
Through the Department of Consumer Affairs. We went through, in which they're an official testing agency, and it was developed through psychometricians and research through psychometricians and the development through subject matter experts.
So my question is 54% pass rate, is that a good pass rate that you feel? To me, that's not meeting benchmark at all for any category, from any educational standpoint. That's a D. I'm just saying for pass rate of licensure.
Right. So in our discussions with OPES, they do not have any concerns right now relating to the pass rate, that seems to be within the normal range of a pass rate for a written examination. It is something that we continue to look at. The combining of the examination was the first step in looking at the RDA written examination after the completion of the occupational analysis. So the examination will continue to be developed and reviewed as we move forward.
Okay, just one other question. If 54% is okay, and you're looking at schools that have a low pass rate percentage, and they are at a 54 or a 44 or a 64, but if 54 is passing, then how can you say that they're low pass rates if, you know, if that's okay, then.
54 is the average among all of the programs.
Okay.
So what we're looking at is the individual examination statistics that Tina had provided in the board meeting packet, and looking at that. There you will see the pass rates that vary from program to program. Those are the rates that we're looking at to develop who will be reevaluated first.
Will we ever look at trying to increase that pass rate?
Well, I think the reevaluation of the programs is the first step in that direction.
Okay.
Yeah, this has been a subject of discussion. It began with discussion of the low pass rate on the RDA practical, but it was noted at that time that there was also a low pass rate on the written. However, I think you're seeing there's a large number of programs with low pass rates that are kind of dragging the average down, and so it may not be. It's a little misleading, I think, to just look at a pass rate across the board like that. And if you go back and look at the individual programs, you know, and kind of see where those are, it gives you a better idea.
I do have to agree, though, it's pretty alarming. In the clinical setting, when I interview candidates to be hired, it's pretty frustrating given the courses that they're taking, if they are actually meeting the needs and getting their licensures based on the information they've given. Oh, sorry. Given the information at interviews, it's like you've asked them a deer in the headlight question. So I would like to see the educational part of it coming from schools to be at a little higher standards based on their curriculum, and also the statistics of passing these different tests be a little higher and a little higher standards.
Are we, once the evaluations are done and the site visits are done on these educational settings, are we looking at doing a new exam after it's all said and done?
We haven't reached that point yet. So I think right now we're in the initial stages of doing the reevaluation, and depending on what the findings are from there, then we'll present that to the council and we'll move from there.
Okay.
Yeah, the exam was developed using the same process that we do for all exams. In other words, subject matter experts are put together, competencies are evaluated and agreed upon, and test questions constructed. And then you go back and set the pass point based on what you think the knowledge should be. And we can have a separate discussion about how that is done. But I think the exam is, you know, since it's a legally defensible, statistically valid exam, it's going to be hard to improve on that very much. So we need to, I think, look at the educational side of things. Anything else on combining the exams? Very good. It's getting a little close to lunch here. Should we go through and start agenda item 9, or do we want to take a break and come back? 12:30, okay. So we'll go ahead with number 9. So this is our discussion and possible action regarding scope of practice for the RDA EF2 as submitted by Joan Greenfield, representative of the RDA EF Association and J Productions Dental Seminars Incorporated. And the proposal is for addition of the administration of local anesthesia, administration of nitrous oxide. Okay, we'll need a couple of minutes here just to change things over.
Okay, I think we're ready.
Just before we started, I was just reminded that there was some public comment on one of the items we just heard. If somebody could just come forward and do that.
Hi, I'm Molly Newland, Dr. Newland from UCSF and University of the Pacific, RDA EF program. The question I had is concerning the, the written exam. Excuse me, it's cold in here. The written exam, and I was wondering if there's ever been any discussion about offering the exam in different languages. It's been my experience both at being a professor at UCSF for 30 years and now with this EF program, that even during our coursework, people who have English as a second language, and many people in the EF program, that's the case, have difficulty conceptually understanding concepts in a language that's not familiar to them. I mean, they can get through basic things, but I contacted the PSI organization. They said some of their exams, I think for plumbers, electricians, and so forth, will offer the exams in Spanish, Chinese, so forth. I'm wondering if there's ever been a discussion about that concerning the RDA and RDA EF written exams. Thank you.
Dr. Witcher, do you mind if I?
Yeah, go ahead, Sarah.
So there is a provision in statute currently that mandates that all dental examinations have to be done in English. So that provision has been applied across the board for all of the board examinations. But this actually has recently come up in the office, and we're looking into whether or not we have the authority to offer the RDA exams in alternative languages. And so I would expect that to be a potential agenda item in the future.
Okay, and I do, because the discussion has been about a low pass rate, and I think that can contribute to that number, because so many of the students taking the exam, English is a second language, so that may affect your actual pass rate. Thank you.
Yeah, that has come up during our discussions in the past. That might be one reason. Okay, I guess we can go ahead.
Okay, before I start with my presentation, I would like to agree with the previous speaker. I think that some of the folks that take our EF2 program that fail the written portion of the exam are also having issues with English as second language speakers. They do take it again and pass it, but I think that does probably contribute to a low pass rate. And when I was still teaching in RDA programs at Sac City College, as we got more and more students who spoke English as a second, third, or fourth language, I think that that does affect some of the results that you're seeing as well. So, okay. Now, for my presentation. Because we have not only new members on the DAC, and thank you for being here and serving us. I'm impressed with some of your comments already this morning. I do want to just go back and say that the EF2 programs became law in 2019, and the first class graduated and became licensed in 2010. Approximately 6 months to a year after DAC was originally formed, we began to come forward to DAC and bring issues up that we felt needed to be changed in regard to the exam and or also the addition of local anesthesia, nitrous oxide. So I want to give you that background that we've been bringing this up now for 5 or 6 years. Knowing that when we first brought it up that there would be a lot of pushback and that we needed to wait, but we needed to bring it forward and have you look at this. So just as a background, so you know that this is not a new thing. All right, so I'm going to start out with the old saying that all roads lead to Rome. And what that really means is that many routes can lead to the same result. And I want you to keep that in mind, that there's always different ways to look at things and how we can do them and how we can accomplish them. But I hope that before we really get started here, that everyone in this room that is a dental professional, not only you, but individuals in the office, have the same goal in mind. And that is to treat all citizens of California with the best possible dental care that we can. And Ms. Peacock, I liked your statement about being passionate about those underserved persons, and so am I, and so are all of my EF graduates, because that's why they're doing what they do. So keep in mind that sometimes we have been traveling down the same path to get to a goal for so long that we don't look at other options or other ways to do the same thing. So, why do we need to have more people doing delivery care in California and all over the country? Well, we have lots of changes in demographics. We have baby boomers who are not only living longer, but living longer and needing more care. We have advanced technology that's changing things, and Dr. Morrow and I have discussed this and how we have to change things in programs to teach dentistry in new ways. Some of you are probably involved in a lot of new technologies in dentistry, advances in evidence-based healthcare and so forth. But we have this huge, unique population in California.
In 2009, the Dental Assisting Alliance and the California Dental Association got together and developed the EF2. I was asked to represent the Dental Assisting Alliance and work with CDA on these policies. And I was amazed at the individuals in the particular room that I met the first day to do this and how they were looking forward at what was coming in need for additional care for California citizens. They saw what was coming way back then. They wanted to deal with it. And one of the ways they want to deal with it is what can we do in restorative dentistry to help access to care? What can we do in the restorative dentistry to help the current dentist survive? Because what's happening in dentistry? Dentistry is becoming kind of corporate. Dentistry is very controlled by third-party fees. Even with Denti-Cal, fees are, at some point in California, Denti-Cal fees went away for adults, as you may recall. And so they put together the most comprehensive package for a non-dentist doing restorative dentistry in the United States. And although I have a little map here of the country where you can see some stars on some other states that have EFs or other advanced care providers for restorative dentistry, you can see that California star is quite big because the other individual states, although they may have FDAs, as they're referred to, those are typically limited in care. For example, a couple of the blue states there, they can only do class 1 and 5 restorations. Some can place but not finish. So there are a number of states that do that, but California at the time and still is the most comprehensive restorative area for a non-dentist to do. Okay. The scope of practice is written in a different format, but I put it in this format so that non-dentists in the audience and non-dentist members of the dental board could understand. So an EF, once the doctor has removed the decay, an EF can do amalgam, composite, glass iron or fillings, impressions for crown and bridge, impressions for tooth-borne appliances, permanent crown bridge veneer adjustment, cementation, and bonding, endodontic procedures, patient assessment, which includes looking for cancer, and evaluating oral lesions, and other procedures authorized by regulation adopted by the board. And that does leave you some options perhaps to add additional functions. We specifically added that, even though it's listed in the Dental Practice Act for other areas, it's listed slightly, it's written slightly differently under each of the categories of assisting. We actually put this into regulation, into statutory language with the legislature. This went through the legislature. You heard today how there's a difference between regulation and statutory. This went through the legislature. It was signed into law by Governor Schwarzenegger. And then we helped you develop the regulatory language for these courses. As you know, because you're in dental assisting, let's take one procedure. Let's take a composite, for example. You notice a composite involves at least 23 different steps, which are technical in nature, and many of them, if done incorrectly, could cause a failure of the restoration. Would you agree, ladies? Yeah, okay. And yet, the EFs do these very, very proficiently and very nicely, and have provided, in many ways, additional access to care for many, many patients. And I have some young ladies here with me today that work in primary care and also in private offices that would like to speak to a few of these issues in regard to the difference that they've made. But what's happening here is a restorative assistant, which is what we call the EF2, is now kind of caught in a dilemma because many of them are doing procedures that are an hour and a half, 2 hours in length. And they run out of local anesthesia in the middle of the procedure. And now they have two choices. Tell the patient, too bad, well, that's not a good idea. Or try to run around and get the office in the office and try to get someone else to give the anesthesia for them. What's happening to the patient? The patient sitting there now in discomfort. One of the chief and most important things we do in dentistry is the care of patient pain and anxiety. And that's not happening here. I think that the EF2 has proven themselves very worthy of and shown the educational level that they have to be worthy of having a continuity in practice with restorative dentistry to add to that scope of practice, local anesthesia and nitrous oxide. Because we didn't want to just run out and do and not do a lot of research, in 2007, well, actually back in 2015, we did a survey to determine how many EF2s were having issues with anesthesia. And 70% of the respondents said they, on a daily, routine, multiple time daily basis, needed to have additional anesthesia for their patient comfort. Okay. That's a huge number. Okay. So as time went along, we decided, well, let's, rather than willy-nilly saying, hey, we want to teach all injections, let's see what injections are really, really being utilized. So we did an additional survey in 2017, and at that time, based on the number of EF2s that were licensed, we had about a 23% response, which statistically is really good. And it turns out that the injections that are most widely used are these. And again, as you know, as assistants, these are locations of nerve endings. So this is the PSA, MSA, ASA, the AMSA, the IA buccal, the incisal and mental, and the intraseptal and PDL. Now, there are other injections. There are other injections that hygiene teaches, for example, that are included in their course requirements. But we found that very few people are using those. So the other injections that were on our list that did not meet the criteria for us teaching and including in our education were these. Okay. We left two injections out, the PASA and the Varanasi Akanasi injections, because almost no one does those injections at all, so we didn't even bother to put them into the results. So we're trying to show you that we're doing this in a very methodical way. There's been a lot of thought go into this. We've been working on this now for 8 years. Okay. So what we're recommending is that we do a course that includes these particular injections to competency, not minimal competency as listed in hygiene's guidelines, but to competency. And that either they're not allowed to do the other injections, or that they could learn to do the other injections once they were certified in a local anesthesia by attending board-approved continuing education programs. The delivery of pain and anxiety control should be done in a timely, efficient, effective, and competent way, because the most important thing that we need to do here is patient safety. Okay. Well, if we were to look at this task and analyze it, what's really needed? What are this knowledge, the skills, and the abilities needed to perform this task? So this is where we're looking at perhaps a different road that has been traveled down. What are those skills, abilities, and knowledge that are required? Well, for local anesthesia, we certainly need to have the EF2 know how to assess a patient history. And even though that patient history has already been looked at and assessed by the supervising dentist, because these would all be direct supervision duties under the jurisdiction of the dentist, patient health assessment is important. Patient health assessment is already part of the EF2 program because they are treating patients now. Medical emergency prevention and procedures, because what we really want to do is prevent it from happening in the first place. And those would be things like vital signs assessment, anxiety assessment, and so on and so forth. Again, already taught in EF2 programs. Anatomy, physiology, overview of body systems, important. We've included that in our curriculum. Chemistry overview as it relates to not only drugs, to understanding drugs and nitrous and anesthesia. Complete head and neck anatomy course, of course. Pharmacology as it relates to local anesthesia and patient medications and interactions. We have a lot of this in the EF2 program already, but it would need to be done an additional aspect, and all aspects of local anesthesia administration, of course.
What would be the requirements that we're recommending? Well, that the individual is licensed as an EF2. This would be post-EF2 licensure. It would not be something that would be added to the EF2 program. They must attend a board-approved competency program at a post-secondary level with specific requirements for administration of local anesthesia, developed by the EF Association and with the board approval. And we have given you specific guidelines in your packet that we just handed you. They may provide local anesthesia at the discretion and direction of the dentist. They may only provide local anesthesia for those injections in which they have been educated in the specific locations that we've mentioned. Program length. The overall length that we're suggesting of the program is 150 hours with 118 hours of didactic instruction, 32 hours of preclinical and clinical instruction. The clinical and preclinical instruction exceeds those guidelines which non-dentist programs such as hygiene have used all over the country for the last 30-some-odd years. Again, completion of a post-secondary level course in head and neck, dental, oral, and histology overview, oral pathology overview, pharmacology, overview of chemistry as it relates to local anesthesia, and all aspects of anesthesia. And we've kind of covered part of that already. I don't know that you want to go through this, but we have provided this for you. But if you look at the handout, if you go to your handout that we gave you for regulatory language, we do list all this didactic information. And I believe it's on page, if you look at page 3. Page 3, line 23, starts the length of the program, which we've already discussed. But if you turn to the next pages, you'll see that there are multiple pages of specific didactic subjects that would be included in the program. I know that you don't have a lot of time today. I know that we only have another 15 minutes left, and I do want to give our former graduates some time to look at this as well. But I hope you can appreciate that if you look through this, that we have done an extremely comprehensive job of providing information. Now, one of the things that happened in 2009 and 10, along with the EF2, was also the development of orthodontic assistant permit and an oral surgery sedation permit. And at that particular time, the Dental Assisting Alliance was willing to help develop curriculum and regulatory language along with the Cal Amos and the dental board members in the form of Dr. Witcher. And he may recall that he and I worked closely together over the internet, sharing regulatory language and the development of curriculum for that program together. And so one of the things that we might look at or consider is a similar idea. What we're looking for you today, and there are two subjects here really, there's really local anesthesia and there's nitrous oxide. And if you would like me to divide that out so that you can discuss those on an individual basis because they are individual duties. But one of the things that we might recommend is that we hope that you can look this over and recommend that this move forward to the board as the addition of a function for the EF2. And one of the things that could happen is even though we have developed very comprehensive educational guidelines here, that perhaps some of you on this committee and or board members who have particular expertise in this area would like to join us so that we could jointly look these regs over and make suggestions for anything you'd like to see added or deleted. So would you like me to stop with anesthesia so we can talk about that first before we go on to nitrous?
What would the council members like to hear? Separately or?
I think it needs to be separately.
Yeah, okay, so, okay, good. So I'm ready for any questions you might have.
Well, I'll start. I'm concerned with the hours that 450 hours of a program.
No, 150.
150, but then there's, I guess it was 400 and something hours of extra, I'm not sure. There was somewhere where it said 450 hours
No, I think
was
you're getting
total.
confused with something that was mentioned this morning, that EF2 programs are 410 hours in length.
Okay.
Right. Specifically, might I ask specifically what subject area you're con?
I don't recall.
So, if there's no further questions on local, I think we're operating at a little bit of disadvantage here in that our RDAEF is not present. I think she would have some comments to add, but that's fine. We can loop her into this. Are there any questions on nitrous oxide administration and the training course that's been, I mean, you think it's a good idea, or you think it's, I mean, clearly, this is a lot of information for us to receive. I think we need to think about the curriculum content, how this compares to other, say, the dental hygiene curriculum that was provided. It takes a little time for study, I think, I mean, it's up to the council, but it was just my own personal feeling. Maybe you would like to tell us how you feel as well.
I'm not prepared to vote on this. I would like to look in more depth and see the hours and the time involved.
I can help you a little bit with if local anesthesia, that non-dentists, basically hygiene on a national basis, and hygiene in California have added for specifically anesthesia. And on a national basis, it's kind of all over the map. It's anywhere from no specific hours to 30 hours maximum, with no specific requirements on number of injections. In California, it is 15 hours of didactic and or preclinical, and 15 hours of clinical. So hygiene's specific content for anesthesia is 30 hours. Now, hygiene will come forward and tell you that they have many years of prerequisites and 2 years of hygiene program. And in fact, they do. I have an advantage, I suppose, in a way, to be quite old and have been around in education way before hygiene got local anesthesia and nitrous oxide. I was teaching at Sacramento City College in the assisting and hygiene programs there. Prior to the addition of local anesthesia and nitrous oxide, hygiene programs themselves, not the prerequisite, but the hygiene program itself, to teach hygienists how to do what they do, was 2 years in length. Okay? After the addition of local anesthesia and nitrous oxide, the hygiene programs were 2 years in length. The only thing that happened was the addition of those two subjects, and according to board DHCC regulations, that added 30 hours to the content of a hygiene program. All right? Now, hygiene, again, will come forward and say they have all these prerequisites, anatomy, physiology, chemistry, all this stuff. We are suggesting that absolutely what's necessary. Head and neck anatomy, absolutely. Anatomy, physiology, absolutely. And shorter versions of anything else that they have that deals with both of these subjects. Because there are, again, as we say, different ways to do the same procedure. So there is very little that was added to hygiene programs in regard to these two particular subjects. I don't know if you were aware of that or not. Okay.
And you're an educator. I mean, what do you think of the feasibility of teaching these duties based on what you teach in your program?
Well, first I have a question regarding other states. Are there any other states that have EFs or dental assistants doing local anesthetic?
There are certainly not any RDAs or equal to that. There are a couple of states that have, of course, gone to mid-level providers, but that's a whole different thing. That's like 3 or 4 years of university level, because they're going to be allowed to practice on their own with specific populations. I was reading an article the other day that did, and there was something in a major textbook by Professor Bassett that writes a textbook on local anesthesia that did indicate that there are a couple of states that allow for dental assist, some higher level of dental assisting to do injections, but I am not aware of what the states are. Yeah. What I need to bring to your attention again is there is no other state that has the quality and quantity of restorative procedures that we did in California. It is unique to California that we can do everything that we're doing. Basically, in restorative area, these people are doing 2/3 of what a dentist does. The dentist removes the decay and walks away. So we do have a unique practice, or scope of practice in California.
Right. Okay, as far as being an educator, I am really for the student getting formal training.
Of course.
Just to make sure that when they do work on patients, that they have the ability to give proper care.
I agree.
So,
yeah, of course.
I was just wondering, with your proposal, are you saying that you are just allowing the EFs, like all the EFs, to take a separate course, or?
They have to be in EF2.
Right, in EF2.
They have to be currently licensed, they have to have CPR, and they have to complete a competency course in local anesthesia.
But as far as courses in anatomy, physiology?
Right, what we decided to do, and thank you, because I should have mentioned that. What happens in other non-dentist programs that administer local anesthesia is that they are required to have prerequisites. We want to have if you wish to call it a co-requisite, we want that as part of their current education. Just a little story. We are a provider of local anesthesia, nitrous oxide and soft curettage for dental hygiene, have been for many, many years. And my last program that I did a couple of months ago, I had 2 women come in from states. They had been hygienists, one for 35 years and one for 40 years. They came in from states that did not mandatorily require they have local anesthesia or nitrous, so they had never done it. The one that had worked for 35 years obviously took her prereqs 40 years before, and the other one 45 years before. Okay, we don't want that to happen. We want this stuff as part of the program. So we're not going to say to the student, you have to go to Sac City College and take a head and neck class. We want that as part of the comprehensive program so that all those things are fresh and new in their minds, because those are directly related to what they're doing. So all of that would have to be content contained in any program that would be approved by the board.
Okay, thank you.
I have a question. You stated that you would require them to take a competency course before. Could you repeat that?
No, what I said is these courses are at competency level. If you look at a lot of regulatory language, it'll say minimal competency. I don't do minimal competency, and we don't want anyone ever to do minimal competency. Probably one of the reasons that we are the #1 EF2 program in California and have been for a long time since it started is because we don't do minimal competency. You are competent in what you do or you don't graduate. So that's why we want to make sure that language is there as opposed to minimal competency.
So are you proposing just for your program
No,
to
no,
have
no.
this?
No,
or
no, no,
other
no.
EF2 programs?
No, you can't
So
do
who's
this.
to say that they're going to be competent as well? as a
Because we're
teacher?
writing regulatory language that say that they must be taught to competency, not minimal competency.
What is the law of how many EFs can be in an office? I know it used to be
3.
3, but what, is it 3?
Any dentist can supervise up to 3 EF2s or EFs.
In
as
an
a-
office.
In an office.
And so
right.
one of your comments earlier was that the reason they need to have this is because they are the dentist need it because the EF is doing a procedure that's 2 hours long.
Or 45 minutes long, or a half hour long, or whatever what happens to be. There's two reasons to have this. One, it should just be part of the scope of practice. They are practicing restorative dentistry other than removing decay. It should be part
Directly supervised by a dentist, though.
Absolutely,
Right.
always, under their direct.
So when you say it's a restorative DA, that's not their job title. Their title is.
I said they are doing restorative
Right,
dentistry.
but you referred to a little while ago as saying that they're restorative DAs. and
They are
that's-
restorative auxiliaries,
but
yes.
that's-
I just have a couple of.
I said we
Yeah.
refer to them and they refer to
Right,
themselves.
okay.
Okay? Yeah.
Just two quick questions.
Sure.
How many RDAF2s are there currently? No, just EF2s. We have EF1s and EF2s. Yeah.
I think you're looking around 1,600, aren't you?
Well, Tina has the numbers. So I do have a question. So you're saying that the dentist has come in, he's prepped the tooth, the RDA-EF is ready to place the restorative material, whether it's composite, what have you. You're saying that now that's going to take you more than a half an hour to place that placement in a patient, and that the anesthetic may wear off, and that's why you're asking for these other, I mean, you're asking for pain management with anesthesia and nitrous oxide, because the procedure you're doing is going to take too long, and the anesthetic will have worn off. What is the criteria as far as why wouldn't a dentist give more local anesthetic if he knew that was going to take that long for his RDAF to do? Why wouldn't he administer more anesthetic before he left the room?
The most commonly used anesthetic typically lasts for pulpal anesthesia about 40 minutes, 40 to 60 minutes. Okay. All right, so that's not going to help. All right. Secondly, I think you're assuming they're doing one filling, when in fact, most of them are doing full quadrant. As dentistry has changed, you know that we're also using CAD-mill restoration. So for example, I know that some people will address this issue, but for example, if someone's having just a single crown, that patient's going to be in the chair for about 2 hours. Of that time, about 15 minutes will be a dentist's contact with that patient preparing the crown. And the rest of that time, the EF is doing a digital impression, designing the crown, so on, so on, so on and so forth. So in that 2 hour time period also, these procedures are not just simple single restorations that are happening.
I guess another part of my question would be then if a dentist was normally doing these procedures, now that an EF is involved doing these restorative dentistry, I would like to know the statistics of how often a dentist would re-inject if that procedures were going for 2 hours long. Is it necessary for an RDAF2 to have that license? And why shouldn't the dentist be the one coming back and giving more administrating the anesthetic to the patient?
Well, we just talked about being efficient, effective treatment for our patients, right? So you're a dentist. Let's say you're a dentist, and she's doing a procedure. You're treating a patient. She needs more anesthesia. Now you're going to interrupt your patient and leave your patient unattended to come back and give additional anesthesia. This goes on all day, and I know that there are people here that can speak to this issue of what's actually really happening, okay? We have heard from people who took 10 minutes running around the office the dentist was too busy. Go ask the hygienist. I can't leave my patient right now. I'm right in the middle of something too. Okay. When we first started talking, kind of as an anecdotal comment, we first started talking about this, hygiene was absolutely livid, and the average hygienist in the office was just irritated as heck. And now most of the hygienists working in the office would say, would you please get local anesthesia? You're interrupting our practice. Now I know organized hygiene is here, and they're going to say the opposite. But a lot of working hygienists would prefer that this go on. It goes with the scope of practice they're doing. It goes with the scope of practice far more then why hygiene needed it in the first place. If you talk to a typical hygienist that works in a standard office, not periodontal office, they might use local anesthesia a couple times a week.
Joan,
EF2s
I
need it
think-
for every person.
I think we need to kind of bring this to a
Right.
close.
Well, I'm just
so,
trying to answer
yeah.
her question.
I appreciate it, but
Yeah, okay.
we are on a time limit.
So just to respond to the total number of EF2s, we have EFs licensed after 2010, which includes the EF2, we call it a modifier, is 531. And of the EFs licensed prior to 2010, 174 have returned and taken that extended course.
You said 500 or 1,500?
No, 530.
Looking at the occupational analysis
EF
from
licensed after
2016, they have the frequency with which this is performed. It's both nitrous and the restorative procedures themselves are pretty far down the list in terms of the frequency. I mean, how many, we've done surveys of this in the past where it was hard to determine how many EF2s were actually doing restorative, where they might need this. I mean, do you have any, you said 70% of how many are actually doing this?
Well, I know, I can only speak to the individuals that answered it, and we had a 23% response to the current number of people that were licensed as EFs. I do have issues with the results that were done earlier and shared earlier today about the EF2 functions that were listed, but it wasn't worth us getting up about it because other people were already expressing that they didn't feel that the information was very accurate. I don't know what dentists they were talking to. If the dentists don't know the difference between coronal polish and a prophy, I guess they don't know the difference between an EF1 and EF2 in regard to answering the questions, because those are not the procedures the EF2s are doing out there. They're doing restorations. Okay.
I think this item will need some further consideration by the council before moving it to the board. Would somebody, well, actually, we need to take public comment on this. I guess we should have a motion. What is the will of the council to do with this? You want to table it for later discussion, or what?
I think we should table it.
So,
I just
Pam,
don't
are you making a motion to table?
Yes.
Yeah. Could I have a second,
I
please?
second that.
Thank you, Pam. Okay. Okay, now with that, we're going to break, and then when we come back from lunch, we'll take public comment then. So we've got a motion on the floor. Now's when we hear public comment on the item. I would just remind everybody not on the council not to discuss this among yourselves, and all the discussion has to take place in the meeting, okay? And so with that, we'll recess until... Yeah. Coming back from recess, this is the Dental Assisting Council. We've had our discussion, and our presenter has reminded me we were going to take this in two parts. We've discussed addition of the duty of local anesthesia. She has a short presentation on nitrous oxide that will follow on this, but we're going to go ahead and this will just be on local anesthesia now. And the motion was to postpone this discussion until we could review the information presented. And I just wanted to ask the maker of the motion if anybody had any additional information they would like to request, that this would be the time to do that. And the handouts, will be circulated. We can email copies of those around. It's just to make sure everybody got them. So is there any other information? I think we had a request for the number of EF2s. I think we wanted some information about the frequency with which duties are performed, and just be thinking of any, I think, Rosa, you had a few things that you would like as well?
Yes, so I am completely happy to see that dental assisting and the scope could evolve in the future. Maybe that's the direction that we want to go. That's great. With that said, there comes a lot of responsibility as scope changes for any healthcare provider. Specifically to the dental assistants, speaking from the field, and that I'm actively in the field, EF2s, I do know that they perform quadrant dentistry majority of the time. With that said, DSOs are growing and are what we see maybe going to be the future of dentistry compared to private practice. So right now, my question is, current EF2s, how many of them are practicing actively in a DSO, where there are maybe 3 to 4 providers, versus in a private practice where there may only be one? With that said, what functions are they performing or allowed to under the dentist? From my experience with DSOs, yes, our EF2s that I work side by side with are doing many of these procedures in quadrant dentistry with CAD/CAM and working on patients for extensive amount of period. But let's also look at private practices. Are they doing those functions where this is really a need right now in the field, or is this something to look at in the future as we evolve?
So you'd like to have some information on how many EF2s are working on DSOs?
Yes. How many EF2s are working in DSOs compared to private practice? How many of them are actually performing those procedures on a routine basis, on a daily basis? And is it really a need at this time? My other question is too, it came up of, okay, if this is the direction that we see we're going in, your program seems that it would be great. You're competent as an educator, but what is the criteria for all educators now to train this down in the field and to make sure that they are competent enough to train this when this dental assistant goes live with the patient?
We actually built that in, I'd have to look it up, but part of the requirement to have a program, we said that if that it had to be a currently approved EF2 program, could only be offered by a currently approved EF2 program, and that currently approved EF2 program had to maintain a pass level on the boards of at least 75, a consistent pass level on the state boards of at least 75% or higher. So that means that not all the programs can offer this course. Because again, we're looking for competency.
Okay, with that, I think we're ready to take public comment.
Can I add one more?
Oh, yeah, sure.
The curriculum, I'm concerned about the curriculum. I'm education.
Sure.
So with site visits going on now with the dental board and having to review curriculum, I haven't seen your curriculum. So that's stuff I would like to see. The new curriculum that you propose to teach these classes. In the paperwork I have right here, I have not seen it.
Well, the paperwork that we gave you is regulatory language, which would require individuals to develop curriculum for that.
So the curriculum has not been developed yet?
The curriculum is partially developed, but not completely, because we don't know what it is you're going to want. But yeah, we have as far as if you're looking for specific terminal objectives and goals that normally would be in effect.
Exactly, that's what you need with curriculum.
Right, but you don't do that prior to regulatory language that specifies what you need to teach.
You don't.
You develop that.
You have approval to have a program first and then develop curriculum? Am I misunderstanding?
No, you develop regulatory language that tells institutions or programs, providers, what they have to do in their program, and they develop the curriculum and turn it into you for approval.
Okay.
Just like your RDA program, or your hygiene program, or your dental program. You develop required language that institutions must do in order to be approved, and they develop the curriculum, and then it's approved.
Okay.
The EF programs had an approval process, and did visitations on all those, right?
Mm-hmm.
Yeah.
Staff has made note of all of the questions that the council members have, and so we'll go back and make sure that we have clarification. If we have any questions, we'll reach out to the individual council members to make sure we have everything captured to help work through this.
Okay, let's move ahead and start taking public comment. I'm going to ask, in the interest of time, because we still have quite a bit to get through, I'm going to ask people to keep their comments to 2 minutes.
Hello, I'm Julie Cisneros. I am a practicing EF2, and I have been an EF1 since the year 2000, thank you, and an EF2 for almost 6 years now. I have worked in a few offices over the years, and each office I've worked at either employed 3 EF2s per doctor or 1. The office I'm currently at now, we have 2 licensed EF2s. It is a normal, everyday occurrence where, for the quality of patient care, we are having to renumb a patient based on what we do all day long. We do quadrant dentistry. We don't do any CAD/CAM. So basically, we have a patient come in and we either anesthetize for seating the crown, or after they've been anesthetized and worked on for 1 to 2 to 3 to 4 hours, there is constantly a need for re-anesthetizing. So that is what I wanted to speak to as far as my experience, and just the overall basis for this is for quality of care for the patient. And everybody knows patients hate coming to see us. So to have the anxiety of not having them wait is something that I wanted to speak to. So I appreciate your time. Thank you.
Thank you.
Lisa Okamoto, CDHA. First off, CDHA thanks the board for including our letter of opposition in the meeting materials. As my colleague Maureen Titus asked at the May meeting, what is the true benefit to the public, the improvement to delivery of care or health outcomes? RDA EFs work under direct supervision. The dentist is required to be present not only to ensure patient safety, but the proper delivery of care and to provide pain management. Inconvenience to the dentist or the RDA EF is not really relevant. Safety and improved care for the patient is. The proposal notes that RDA EF2 services are technical in nature. We believe that the delivery of any kind of anesthesia, including local anesthetics and nitrous oxide, is definitely not just technical. With the on-the-job trained career pathway, an RDA EF2 might only have the equivalent of a single quarter or semester of formal college education. This is delineated in CDHA's letter. Dental hygienists are referenced. Hygienists are federally classified as diagnosing and treating healthcare professionals.
Could you summarize, please?
RDA EFs are not. We believe that a comprehensive foundation in biomedical science is part of a hygienist and should be any proposal as part of basic education. Thank you.
Thank you.
Afternoon, council members. Lori McDonald. I am the vice president of the California Dental Hygiene Educators Association, so I'm here on their behalf. The Educators Association surveyed the 27 dental hygiene programs, and 68% responded with the vast majority of comments focusing on concerns for patient safety with administration of local anesthesia and nitrous oxide by RDA EFs. All dental hygiene programs are required to graduate competent oral healthcare professionals as mandated by the Commission on Dental Accreditation. Close observation with a required 5-to-1 student-faculty ratio during the student's second year of their program ensures students attain clinical competence and develop appropriate judgment. It takes a sufficient number of patient experiences and over 448 clinical hours with faculty observation, and that's not counting the 75 hours of preclinical anesthesia lecture lab course for them to develop the critical thinking skills necessary to treat patients with systemic conditions who've been prescribed multiple medications which can negatively interact with local anesthesia and nitrous oxide. The proposal for RDA EFs to administer local anesthesia and nitrous oxide is not supported at this time by the members of the California Dental Hygiene Educators Association due to the lack of the education in the basic sciences, dental hygiene core curriculum courses, and sufficient patient experiences which would be detrimental to the overall safety of the patient. Thank you.
Okay. Good afternoon. I'm Dr. Vicki Kimbrough. I'm a dental hygienist. I'm also the director of dental hygiene at Taft College and the owner of Purple Pen Seminars, a company that also provides the local anesthesia and nitrous oxide course for hygienists moving into California from out of state. I'm opposed to the RDAEF anesthesia proposal as it currently stands. All dental and dental hygiene programs require Quota accreditation. RDA or EF programs do not. I was an on-the-job trained dental assistant and took the RDA test at one point. 20 years later, I chose to go into dental hygiene. The amount of prerequisite sciences and core curriculum was nothing I expected after working in a dental office for 20 years. I thought it would be easy, and it wasn't. Once I realized patients could suffer injury and even death due to local anesthesia, I appreciated the massive educational foundation I had to endure. If this proposal were to move forward, an equivalent education to dental hygiene would likely be needed. Courses in anatomy, physiology, organic or biochem, psychology, head and neck anatomy, pharmacology, patient management, medical emergencies, pain management, ethics, and jurisprudence. This is a minimum of 480 lecture hours, 360 lab hours, plus another 448 clinical hours of direct observation of local anesthesia administration. All of this would likely culminate in an associate's degree. Thank you.
Linda Brookman, former dental assistant, RDH and RDHAP. Also an educator at USC, Oster School of Dentistry. And I'm just going to paraphrase, and I support all the former speakers on the my agreement with this proposal. My concern is for the dental patients that would be receiving the anesthesia and sedation from trained assistants who have not been fully educated in head and neck anatomy, physical evaluation, pharmacology, behavior issues with the patients, etc. I'm just paraphrasing this. As an individual dental hygienist and RDHAP, as well as a full-time educator in a dental school, I highly urge the Dental Board of California to deny this proposal that could potentially harm public citizens of California. It would be an important decision in the Department of Consumer Affairs. Thank you for listening to me. And I've also, I brought in some letters from Dr. Malamed, from our dental hygiene director, Diane Melrose, and I submitted my personal letter as well. Thank you.
Good afternoon, committee members. I'm Anthony Lum from the Dental Hygiene Committee, Executive Officer, and I just want to echo what has already been said, so I won't duplicate that. But I just wanted to clarify a couple of issues here in that it was mentioned that we license under minimum competency. We don't judge on minimum competency. We judge on the qualifications that have been completed and requirements for the license. If an individual has completed all of those requirements according to the schools, then we accept that as that person being competent, not minimally competent. A second thing is in regards to the 30 quote hours in regards to the local anesthesia and the like, that's in addition to, that has been incorporated into the already existing 2-year curriculum. So the educators have already spoken to that, so I just want to point that out, that that's all inclusive in addition to background education that they've accumulated. Third thing and the last thing that I wanted to point out is that in the meeting materials, it indicates in there that there haven't been any reported incidences throughout the states and California about injection problems. However, when it kind of bugged me because it has been brought up since I've been with the committee for the last 6 years. So I did a little research, and the only reporting requirement that I found was it would be unprofessional conduct if you don't report it, if that patient died, or if the patient had to be admitted to the hospital for at least 24 hours. That's according to Business and Professions Code 1950.5, subsection X. That's the only reporting requirement that I saw. So unless your patient dies, you don't need to report any other issues. So I just wanted to clarify that. Thank you.
Hi, my name is Susie Jordan, and I'm an EF. Been practicing, was in the first class in California, and I also served on this board for 2 years, trying to get this to agenda, which never happened. It was very, very frustrating. In the real world, what happens is our high blood pressure patients, special needs patients, run out of anesthetic. Seatiness doesn't last. You're right in the middle of doing a quadrant. The patient's in pain. The doctor's busy in another room. If I could just infiltrate to take care of this patient, which I know you all care about, this is our problem as well. That's what we want. We want our patients to be comfortable, no anxiety, take care of what needs to be done in a timely manner with no pain. In 1984, I had to take a full semester of anatomy to get my x-ray license. Things have changed a lot, and we don't do that any longer. We don't need to. What needs to be done is the right, safe practice school. Of course, we're going to take that school. Of course, we're going to make sure we all are licensed properly. It's not a question to even be asked. That is just silly. But anyway, I just wanted to let you guys know in the real world, it is needed more than 4 or 5 times a day. And I have a general dentist that I work for, and one dentist there. It's not a mill, or we don't have a lot of overturn. It's just a regular general practice in Napa, and it's needed. It's much needed. Thank you.
Hello, my name is Dana Tubbs, and I'm an RDA. I've been in dentistry for 25 years. I've been an EF2 for almost 2 years now. I live in a rural community in Northern California. We have a population of about 13,300 people. I work for a rural health clinic that we provide services for underprivileged patients that is made up of about 40% pediatric dentistry, 10% geriatric, 15% mentally and physically disabled, and 35% of the working class that is still considered the poverty level. What I have found that when we're doing quadrant dentistry, when I'm working on a child that has mental issues or has a hard time sitting still, they become unnumb, and I have to wait for the doctor to come back in to get the patient more numb. Well, I've lost the ability to work on the patient comfortably because they've been sitting there for a long time, and it would be better for the patient. The quality of care is better for the patient when they're there just for the amount of time they need to be there, not for 20 minutes, 30 minutes longer. When you're working on the disabled patients that have a hard time laying back and they're having to sit there longer because they have to wait for more anesthetic, they're uncomfortable, and the quality of their visit is not comfortable for them. And definitely the reason why we're there for them is to give them the quality of care that they deserve. Yes, so for me, I think it's important that the EF should be able to give local anesthetic to provide proper care for our patients so that they're not sitting there longer than they need to.
Thank you. I'm going to ask the speakers to not repeat points that have already been made. So if you have new information, we'd be interested in hearing that.
Thank you. My name is Denise Desert, and I'm practicing EF2 for about 3 years in Modesto, California. And I won't repeat anything that you've heard, although I would just like to say that I echo all of my peers here today. And I would like to request that, given the added information that obviously needs to be explored by you all to make this decision, that we address this again in November at the meeting. Thank you.
Real quick, I'm an EF2, Melody Randolph. I'm also a dental assisting educator, and it seems to me that the biggest issue is the educational component. It seems to be the arguments on both sides is how much education this person would have. And I kind of have that same reservation even as an EF2 myself is, is the education going to be high enough to make these people competent and skilled to be able to do this? But that's within our purview to set those parameters. So I think if we can come together and negotiate a minimum educational requirement, be it require the candidate to have an Associate of Science degree or have to whatever, we can compromise and still make this happen and make everybody happy, making the educational level high enough that we all feel comfortable that our patients are going to be safe. Because again, it has to do with patient safety and access to care. So instead of being a barrier that we can't do this, make our educational level high enough that we would all be comfortable and patients would have this access to care.
Is there any additional public comment on this item? Seeing none, in the interest of time, I'm going to ask the council if they would like to receive the information on nitrous oxide as a submission by email. It will repeat a lot of the material we've already had. We're going to table this for later discussion. So I think we've heard public comment on both nitrous and local administration. I mean, it's up to you what we would like to do here, but I'll make that suggestion.
Yeah, I would like to receive more information via email in regards to both.
Okay.
Because I do agree with the last speaker. It's the education that we're all having an issue with. And with that being said, if we can all come together, just like she said, I don't think there's an RDA that can't do it. Right now, our issue is the education.
Thank you. Did you have any closing comments?
Yeah, a couple things. One, I do want to just mention something about nitrous oxide, and that is the EFs are already working on a patient under nitrous oxide. If this particular patient wants nitrous oxide, the dentist has them under nitrous oxide, cuts a preparation, and walks out. Under ADA guidelines, anyone actually administering nitrous, as in being responsible for changing settings and doing things, because now the EF is kind of shifting from monitor to more of an administration status. It's not legal for them to do that, and they're not illegally doing it. But they are now with this patient for 45 minutes to an hour to 2 hours, in which time usually the gas percentages need to be changed. So one of the reasons we brought this up, and this is not as big an issue as anesthesia because lots of people don't use nitrous, and that's why we're making them optional permits. But for something for you to seriously think out, you are actually now have people providing long-term dental procedures with their patient under nitrous oxide, and they are not properly educated to do so, and they should be. And the guidelines for nitrous oxide are much simpler to follow. They are developed by the ADA, and those are the guidelines we're using. One last comment in regard to a couple of comments that were made here. You noticed that a lot of the people that were in opposition to this were saying that we needed head and neck anatomy and so on and so forth, things that I just said would be included in the program. And one additional thing to Mr. Lum, your own guidelines for local anesthesia, nitrous, and curettage say the student shall be at least minimally competent, and that's why we got the minimal competency that DHCC has. Their own guidelines specifically say minimal competency, and that's why we came up with that term. Okay.
So we have a motion on the floor. We've had discussion. The motion is to table this discussion item to postpone it until agenda time is available, next meeting if possible, and to request additional information, as you all have done, to be considered in the meantime. So I just restated the motion. Are we ready to vote? Okay, let's call the roll.
Contreras?
Yes.
Davis Washington?
Yes.
Olagi?
Yes.
Ovard?
Yes.
Peacock?
Yes.
Rodriguez, absent. Witcher?
Yes.
Okay, the motion passes.
Okay, with that, I think we can go ahead and adjourn.
Ask one more question. Would the committee, the dental assisting committee, be open to forming a blue ribbon committee to work on this issue? Because tabling means, okay, now what happens? You say you want more information. How does that occur?
Well, you submitted some information to us. They've requested additional information that will be researched and brought by staff. That information will be circulated, and then we will discuss the findings at a future meeting.
So I guess I go back to my question, would the committee be open to a fact-finding committee of subject matter experts on this committee that would work on this project?
I think maybe if you, excuse me, if we take the committee and we kind of research and on our own and come back and table this to November's meeting, and at that time we can maybe make a decision.
Okay.
Of what we want to do or not do. But give us an opportunity to look at the materials, do our own little research, and we'll get back to the situation.
Okay.
Yeah, I would encourage you all to reach out and to work through staff on this to help get this formulated and to get an agenda item put together for next meeting, provided there's time available. Thank you.
Thank you very much.
Okay, thanks, Joan, for your presentation. Appreciate it. Thanks. Okay, with that, we're adjourned, and we will move back to the board meeting. Thanks, everybody. Great job.